Assalamu alaikum, everyone. I hope you're all doing great. Thank you guys for joining this one. My name is Mohammed Alfuwais. For those of you who don't know me, I'm a fourth year medical student. Inshallah, this will be the second part of the Endo-Repro crash course and my last session of this year for you guys. So inshallah, today I'll be covering Repro. This will be a bit of a long session. So if we can't finish everything today, like for example, I'm going to try to finish gynecology and obstetrics for sure. If we can do breast and it's not late, then we'll do it. If not, then we'll keep it for an hour session tomorrow, maybe or something. But we'll see how the session goes, inshallah. I'll try to speed up and give you guys just high yield facts for every single thing in this block, inshallah. So as my sessions, I need you guys to be very interactive. I'll be asking questions at the same time, explaining and telling you guys details to remember for the exam, inshallah. So let's begin with gynae, okay? So the first thing is just understanding the regular anatomy. We have the vagina, and past the vagina, we have the cervix, which is the first part that you see, for example, in speculum exam. Then you see the external os of the cervix, which looks outside. Then we have the internal os of the cervix. The internal os of the cervix will look into the uterus. Now, the uterus, the thing that's very important to remember is the layers of the uterus, specifically these two. You have over here the endometrium, over here the myometrium, which is the muscular part and the biggest part of the uterus. Past it, it's not really important. Another thing is you have the ovaries with the ovarian ligament connecting to the uterus, and then you have the fallopian tubes. From the fallopian tubes, you have firstly the ampulla, then the infundibulum, which is the first part of the fallopian tubes from the fimbria. Then you have the ampulla. The significant part of the ampulla that I want you guys to remember is two things. Number one is it's the site of fertilization, if it occurs. Number two, it's the most common site of ectopic pregnancies. These are the two important facts I need to remember. Then you have the isthmus, which is the thinnest portion of the fallopian tubes. Significance of this is if ectopic pregnancy happens here, the risk of rupture is very, very high because it's very thin, okay? And that's just clinical implications of this. Now let's go into a bit of details about the anatomy of the cervix. So the cervix has two parts, the endocervix, which is basically this portion, which is continuous with the uterus. Then the ectocervix, which is continuous with the vagina. So the important thing to remember about the cervix is the cells that's lining it. The endocervix is lined by columnar epithelium. Ectocervix is lined by squamous epithelium. The junction between the columnar epithelium or the endocervix with the ectocervix or the squamous epithelium is something called the squamocolumnar junction. Now, what's the transformation zone? The transformation zone basically during puberty, what happens is something called cervical ectropion, okay? Or basically, the endocervix that's over here, the columnar cells, will go out, okay? Now, what happens is this part over here will be lined by columnar epithelium. This columnar epithelium cannot withstand the acidity of the vagina, for example. So what happens is this is going to cause metaplasia, where it changes from columnar cells to squamous cells, forming this part of the ectocervix. This part of the ectocervix, which is going to be the squamous, the new squamous epithelium, is very weak, okay? So infections such as HPV can cause a lot of pathologies there of this transformation zone. This transformation zone, the only clinical significance of it is it's the weakest point where you have malignant transformation and HPV infection in that area. This is the cervix. Then we go to the ovaries very quickly. And the important thing in ovaries that you need to remember is its relationship in the menstrual cycle, what happens in the menstrual cycle. And second thing is the different types of cells in the ovary. And we'll talk about the different types of cells in more detail, inshallah, when I discuss the tumors. So in the menstrual cycle, in the very beginning, you have many follicles, okay? And then FSH will pick one of this follicle and it will grow it. Obviously, many will grow at the same time. However, only one will be ovulated. So you have primary follicles that form, then you have the secondary follicles, then the Graafian or the tertian follicle, then you have ovulation afterwards. What controls the growth and development of this follicle? FSH. Now, in the oocyte itself, or the follicle, you have different cells. One of these cells is a granulosa cell. Now, granulosa cells, you guys tell me, what do they synthesize and secrete? What hormone? Estrogen, perfect. So what will estrogen do? Estrogen will go firstly and cause positive feedback, and we'll talk about this in a second, and cause more FSH, okay, to continue growing the single follicle. At the same time, this estrogen by the granulosa cell will go to the endometrium in the uterus, and it will cause proliferation of the endometrium, okay? Basically preparing it for implantation later on, okay? So then you have FSH that keeps on growing, estrogen that's causing positive feedback. Then you have the LH surge. This LH surge will cause ovulation, okay? Now, after ovulation, if there's fertilization, it will implant in the endometrium. And then after the implantation, it will stay there basically, and something happens. If there's no implantation, something else happens. What happens? So firstly is you have the ovulation. After the ovulation, the remaining part of the follicle, you have formation of the corpus luteum. Now, corpus luteum secretes what? You guys tell me. Progesterone, excellent. What will progesterone do? It will maintain the endometrium, maintain it, increase its vascularity, increase its secretions. The basically making the perfect environment for an embryo to grow. Okay, so that's the corpus luteum. The corpus luteum will stay there, and if there is implantation, it will stay for 8 weeks. If there's no implantation, it will die. What will maintain the corpus luteum is HCG if there's implantation. Okay, the corpus luteum won't die. If there's no implantation, there's no HCG, beta HCG, the corpus luteum will die. Now, the corpus luteum, when it dies, it turns into this corpus albicans. Now, what happens when the corpus luteum dies? Progesterone drops. This causes the endometrium to die, hence causing menses. Okay? To explain this, I'll explain the menstrual cycle one more time and very quick, but this is basically the menstrual cycle. Okay? Now, in terms of the layers or the amount of cells that the different cells that the ovary has, there's many different types. Firstly, you have from the follicles itself, you will have the surface epithelial cells of the ovary itself. You will have germ cells, and then you will have stromal or sex cord cells, such as granulosa cells, theca cells, and so on. Okay, so these are the three important cells or types of cells: surface epithelial cells, germ cell, and then the stromal cells. Okay, this is important for the tumors later on. Now, when you're assessing basically gynae, okay, all reproductive organs, the first line imaging modality is ultrasound. Okay, first line in any disease. Okay, now ultrasound, there's two ways to do it: either transabdominal or transvaginal. Transabdominal, the probe is in the like on the surface, and you're just looking from the abdominal wall downwards. Okay, so over here you have, for example, the bladder. Under it, you'll have the uterus, cervix that's over here, and then the vagina. Okay, so this is transabdominal. The probe is somewhere over here, and this is the abdominal wall. Okay? A better modality is transvaginal, which is basically you put the probe into the vagina, and then you can assess the reproductive organs through that. Why is it better to do transvaginal? As in transabdominal, you might have someone who's obese. You won't be able to visualize the structures properly, and it has low sensitivity, low specificity to show a lot of different disorders. Okay, transvaginal, you're directly in the reproductive organs, so you'll be able to see it very clearly. Important thing to look out for in an ultrasound of a uterus is this, which is the endometrium. This is the endometrial lining. Very important is its thickness. In a postmenopausal woman, specifically, if this thickness exceeds a certain amount, this is something that we call hyperplasia. This certain amount is 5 millimeters. If it's more, hyperplasia. And this is something very scary and dangerous to look out for. Other than that, you have the myometrium and then the perimetrium, which is basically all the different coverings or serosa of the uterus outside of that. Okay, so this is the first line that you do for, if you have imaging question, which imaging modality you do for reproductive organs, first line is ultrasound. Then you have MRI. When would you do MRI? What do you assess for? Muscle or myometrial diseases, such as two of them, either fibroid or adenomyosis. And or the second indication is usually to look for invasion. Okay. If someone has endometrial cancer and you want to look into the invasion, you can order an MRI. That's pretty much the gist of MRIs. Now, in terms of the uterus orientation, obviously you have anteverted, which is lying on the bladder, and then retroverted, which is posterior lying, okay? And this is the rectum posteriorly. So that's pretty much uterine MRI. Now, the function of repro is menstrual cycles, okay? It controls menses. Now, as I said, you have the first day or when menses occurs. After it, you count, okay? So what happens over here is obviously menses, you have dying of the endometrium, but in this case, you start to have FSH that's forming. The FSH will go and pick a follicle and grow that follicle, obviously multiple, but only one will ovulate. And these follicles will synthesize estrogen through granulosa cells. Estrogen will go back into the pituitary and the hypothalamus, causing positive feedback. And what this will do is it will increase FSH more, this green line, FSH more, to cause more and more development of the follicle. At the same time, it's going to grow LH later on to cause the LH surge, which is around 14 days, okay? So once LH surge occurs, ovulation occurs, then at the same time, at this stage, which is the follicular phase or the proliferative phase, the endometrium is growing, okay? It's proliferating. After the LH surge, you have the ovulation. And then what happens with ovulation? LH and FSH will go down. However, because of the corpus luteum, you'll have progesterone going up. What will progesterone do? It will go to the endometrium and will cause it to increase its vascularity. So you'll see spiral arteries and increase its secretions, okay? Now, if you have implantation that occurs, then the corpus luteum will survive and will keep this progesterone going, and it's going to maintain this endometrium. If there's no implantation, no fertilization, corpus luteum will die, turn into corpus albicans, progesterone drops, and this will cause menses because there's no more progesterone controlling the arterial supply or the secretion. Most important thing is the arterial supply, okay? It will cut off the arterial supply and then you'll have menses, okay? This is the menstrual cycle. Now you guys tell me the stages of the endometrium. First thing, we'll have proliferation. Then you'll have, after proliferation, secretion, spiral arteries, and then you'll have menses. So this first picture, picture A, what is shown in picture A? Proliferation. Why do I say this is proliferation? You can see mitosis occurring, okay? So this is proliferation. Proliferation is controlled by what hormone? Estrogen, excellent. How about B? B, you see one clear sign. Firstly, tell me what day is shown in B, if you guys can tell. 16th day, good. What happens is this after ovulation or before ovulation? Just tell me that. After ovulation. What do you call this sign? Subnuclear evacuation, okay? Basically, this is the cell, one singular cell over here. This is the nucleus. Subnuclear, below the nucleus, there's a vacuole or space. Hence, we call it subnuclear evacuation. Subnuclear evacuation happens after ovulation, so around day 16, okay? So this picture over here, what's shown in picture C? What's happening in picture C, if you guys know? There's, yeah, good. There's secretions, okay? So secretory phase. Picture D, there's an important thing over here. What is this? Edema and spiral arteries. Then E will have inflammatory cells that's beginning to form decidual cells. I cannot pinpoint where any of that is in this picture because it's very low quality, so just take it word-wise. And then F, what's happening in F? Very necrotic, ischemic, menses. Good. Okay. Recognize these images, you might get this in OSPE, okay? It'll have 5 of these images and pick which one, for example, in the question, which one is for proliferative, and you pick picture A, okay? So know these pictures. Now, very important is the normal menstrual cycles, okay? The age, number of days, and the frequency, bleeding, and pain, okay? This will relate to all the pathologies that we're going to talk about, all of them. Number one is age. First, we have 2 ages to look out for, age of menarche and age of menopause, okay? So menarche happens around, it's an average of 11 years, 12 years of age. So you have a range, 9 to 15. If it's below 9, it's pathological. If it's above 15 to 16 years of age, it's pathological. So if you have before 9, this is something, for example, precocious puberty, okay? If it's above 15 to 16, this is amenorrhea, okay? The patient still does not have menses, okay? So this is amenorrhea. Then we explore the causes of that, okay? Remember the age, 9 to 15 to 16. Then we have the number of days. The number of days of menses, it's usually every 28 days with an average of, it's average of 28 days and then a range of 21 to 35 days. If it's below 21 days, it's called something. If it's above 35 days, it's also called something else. Okay, and we'll talk about these terms. Usually, the menses will last for 5 to 7 days. Okay, something else is menopause, which I forgot to mention in age. Menopause, the average age is 45 to 55. Okay, and we'll talk about menopause later. Bleeding is very important. Now, bleeding, when you comment on bleeding, you comment firstly about the amount. Usually, it's below 80 mLs. If it's above, it's abnormal, okay? The average is 30 to 35. Another thing to comment on bleeding is if it's with the cycle or irregular from the cycle, okay? So does it happen every 28 days? Does it happen with the menses? Or does it happen in between? Or it's irregular, okay? This is very important. The next thing is pain. Pain in a menstrual cycle is very normal. If it doesn't interfere with day-to-day life. If it does, this is something else, okay? This is a whole different differential, okay? And we'll talk about this in these slides. So first, you guys tell me the definition, or tell me the term, and I'll tell you the definition. Firstly, you have severe pain during the menstrual period that interferes with day-to-day activity. Good. This is dysmenorrhea. And we'll talk about this very soon, okay? Dysmenorrhea, pain, okay? Pain that's interfering with day-to-day activity. So for example, missing uni, for example, missing work, okay? So that's dysmenorrhea. Now, second definition or second term is prolonged or heavy menstrual bleeding at regular intervals. Menorrhagia, excellent, okay? The key term is prolonged or heavy bleeding at regular intervals. How about if someone has bleeding that's irregular? This next definition. Metrorrhagia, excellent. How about if you have heavy or prolonged bleeding at irregular intervals? Menometrorrhagia or metromenorrhagia. Good. Okay. These terms are very important because you will get an MCQ and it'll give you the definition and you guys put the term, okay, as the choices. So this is very important, okay? Now, if someone has not heavy bleeding, but spotting that's occurring basically between the regular menstrual periods, what do we call that? Intermenstrual spotting. Excellent. Good. Okay, or bleeding. Now, as I said, usually menses happens every 28 days, okay? With a range of 21 to 35. If it happens every 21 days or less than 21 days, what do we call this? Polymenorrhea. Excellent. How about if it happens 35 to 6 months? Oligo. How about if no uterine bleeding for 6 months or longer? Amenorrhea. Excellent. Okay. These are the terms. Know these terms very, very well. And I'll basically keep using them when I talk about the pathologies and the different clinical stuff. Okay. Now, the first thing we'll talk about is dysmenorrhea. Again, dysmenorrhea is severe pain that interferes with day-to-day activity. Okay. Now there's 2 of them. I will give you a feature and you tell me which one. Is it primary or secondary? Someone is complaining to you with severe pain that's limiting their activities at the onset of menses or right before it. Primary dysmenorrhea. Excellent. Someone is complaining to you with severe pain 3 to 5 days before menses, and it goes away slightly during onset of menses. Secondary. Excellent. Okay. So these are the terms. Now, which one of the, okay, actually tell me, what is the main thing, the main pathophysiology of primary dysmenorrhea? Main pathophysiology. One word, prostaglandin. Excellent. That's all you need to remember. Prostaglandin. Okay. So primary dysmenorrhea, just to explain the term. Primary dysmenorrhea is when you exclude every other cause of dysmenorrhea or pain, which is all the causes of secondary dysmenorrhea, then you can say this is primary. And it's due to prostaglandin. Why prostaglandin? Is because of the blood supply. It cuts off the blood supply, and then you'll have very painful and cause ischemia. Okay? So this is dysmenorrhea. Now, for secondary pathophysiology, it has many, depending on the underlying cause. Okay? Now, management of primary. Give me one drug that you can give. NSAID. What other drug can you give? OCP. Excellent. And then you reassure the patient. Okay? NSAIDs are very important. Why? Because prostaglandins. Okay? So you inhibit prostaglandins, you stop primary dysmenorrhea, or just stop the menstrual cycles as a whole through OCPs. Okay? Now, something else that's important to remember is PMDD, or something called premenstrual dysphoric disorder. There's another word for it, or another description called PMS, premenstrual, I forgot the actual full word, but anyways, premenstrual syndrome or something, PMS. They're very similar. The differences is in the criteria that you diagnose it with. Now, this is where you have severe affective symptoms and behavioral changes that occurs that basically disturbs daily living, okay? Now, the way you diagnose it is a survey. You survey the patient. What do you survey them? You need to have more than 5 symptoms from the 11. There's 11 symptoms, 5 of them. More than 5, diagnosis of PMDD, okay? So this is depressed mood, anxiety, anger, and so on and so forth. That's the high yield number 1. High yield number 2 is, what is the first line management of PMDD? You guys tell me. First line. Other than reassurance. Support and reassurance, lifestyle as well, okay? Don't give drugs, first of all. Just start with reassurance, supporting the patient, lifestyle modifications, okay? If you were to give drugs, what 2 drugs can you give? So you can give either or SSRIs, or you can give OCPs, okay? So these are basically the drugs that you give for PMDD, and that's all you need to know for PMDD. And you can skip the whole lecture from these 2 slides, okay? Now, this patient is a 47-year-old woman that comes to the physician because of fatigue, difficulty falling asleep, night sweats for the past 6 months. Her last menstrual period was 13 months ago. She quit, no, ignore this. Pelvic exam show vulvovaginal atrophy. What's your diagnosis? Menopause, excellent. Why do you think it's menopause? Firstly, age. Look at the age. She's in the range. 45 to 55 is the mean age. Number 2 is the symptoms, okay? Symptoms, the most important symptom of menopause, most common symptom, is going to be hot flashes. Another thing is more than 12 consecutive months of no menstrual periods, okay? Perfect. Now, what is the most common cause of postmenopausal bleeding? Most common cause, atrophic vaginitis, which is what the patient has, okay? Because of anovulation, obviously. So what happens in atrophic vaginitis? It is the most common cause of postmenopausal bleeding. Remember that. And it's because of no estrogen, because of no ovulation. With no estrogen, the vaginal wall or vaginal cells or epithelial lining will thin. So it can easily bleed, basically. So that's why you have atrophy, okay? Because of low estrogen. So how do you manage vulvar vaginal atrophy? Simple. You give estrogen. Okay, perfect. Topical estrogen. Okay, so this is menopause. Now, what one single lab investigation confirms this diagnosis? FSH. Excellent. Increased FSH. Remember FSH. Okay, so that's pretty much menopause. Now, we're going to go into abnormal uterine bleeding, which we'll talk about basically all the pathologies in repro in one go. So, abnormal uterine bleeding, the best mnemonic to remember is palm cone. Okay, P for polyp, A for adenomyosis, L for leiomyoma, M for malignancy, endometrial malignancy, leiomyosarcoma, whatever, with hyperplasia, also an endometrium and endometrial hyperplasia as well. Then you have coagulopathy. So if anyone's taking, for example, antithrombotics, anticoagulants or something, or has bleeding disorder, you think of it as a coagulopathy. Ovarian dysfunction, okay? So if a patient is coming to you and they are around 12 years of age and they have abnormal uterine bleeding, the cause of abnormal uterine bleeding is anovulation, which is probably one of the most common causes of abnormal uterine bleeding, anovulation, okay? And it has two peaks, one in the beginning, age of menarche, because it's irregular, and number two is perimenopausal, okay? Then endometrial hyperplasia, endometriosis, something like that. Then you have iatrogenic, such as during a DNC, dilation and curettage. For example, if someone's using implantable or sorry, IUD, for example, a intrauterine device, IUD, such as copper IUD or progesterone IUD, and we'll talk about these. Then not otherwise classified due to any other cause, okay? We'll talk about them one by one. Now, in terms of when does it happen, this is very important. Obviously, adolescent age, the most important cause is anovulation, and you will get a question on this. Okay, you will get a question on this. Someone who's around, let's just say 16 to 9 years of age, coming to you with abnormal uterine bleeding, what's the cause? Anovulation because of menarche. Okay. Then reproductive age is a lot of other stuff. Perimenopausal, again, anovulation becomes very important. Postmenopausal, most common cause is atrophy of either vulvovaginal or endometrial atrophy. Vaginal atrophy is the most important. Then other diseases such as cancer, polyps, hyperplasia, and so on. Okay, remember these ages because it's very important to remember. Now, we'll start taking it one by one. You have this patient who's coming to you with severe pain that happens with menses, with heavy blood, more than 100 mLs. They also complain to you of painful urination and painful defecation. Good. This is endometriosis. Endometriosis is pretty much the endometrial glands and stroma somewhere else, okay? Outside of the uterus, fallopian tubes, ovaries, pelvic wall, GI system, urinary bladder, anywhere else, okay? Now, there's four theories for it. Basically, you have the what's it called? You have firstly direct invasion, ascending or whatever. Then you have metaplastic theory, which is the most important one, through lymphatics, and there's one other one. I forgot what the last one is. Metastatic, lymphatic, direct ascending, and then there's one more, if you guys remember. Stem cells, good. Okay, perfect. So these are the four theories of why endometriosis happens. For in terms of the clinical presentation, very important. Remember this menorrhea, dyspareunia, which is basically pain, basically. Dysuria, painful urination, and dyschezia, okay, which is painful defecation. These words are high yield to remember for endometriosis. Diagnosis, you obviously have to get a sample of the tissue that's involved. So this is basically evidence of endometrial glands with a stroma surrounding the glands somewhere else. In this case, it's in the colon, okay? So this is endometriosis. Now, one place it can spread to, and the most common, is ovary. And it presents with this. What is seen in this image? in image A, chocolate cyst. Why is it chocolate cyst? Basically, this is endometrial tissue in the ovaries. Endometrial tissue is responsive to hormones. So when you have the follicular phase, estrogen will go up. This tissue will increase in size. Progesterone, then after ovulation, it will become more vascular. Then you'll have menses. You'll cut off this vascularity and it will bleed. And it bleeds into the ovary. So this is a chocolate cyst. It's not specific to endometriosis, it can happen somewhere else or in some other diseases. However, in your block, in your exam, chocolate cyst, think of endometriosis, okay? Tamam. How about this patient? Has dysmenorrhea, has abnormal uterine bleeding, and yeah, and then you do an MRI and you see this in the myometrium, adenomyosis, good, which is basically endometrial glands and stroma in the myometrium, okay? So this is adenomyosis. There's nothing else to it, basically. It's estrogen responsive, again, because endometrial glands and stroma, so it will increase in size during estrogen and then progesterone, then it will cause the pain afterwards, okay? These white spots are just basically showing there's blood here, and maybe the secretions also of the from the secretory phase, okay? Now, how about this patient? What do they have? Same presentation. It's a combination. Okay. So this patient has adenomyosis with a fibroid. Okay. Or a adenomyosis inside the fibroid. And we'll talk about fibroid and how it presents later. Okay. But it's very similar, just one key term that I'll tell you guys. Basically, this is the whole fibroid. These small little dots basically in it is the adenomyosis. Okay. You do biopsy with histology, you can see endometrial glands and stroma. تمام. This is why it's an adenomyosis inside a leiomyoma. تمام. Now we'll get to a patient with dysmenorrhea, abnormal uterine bleeding, and a sense of fullness or heaviness in the pelvis. And maybe you can palpate a mass. What does this patient have? Fibroids, excellent. Or another word for it is leiomyoma. This sense of heaviness or fullness, pelvic heaviness, is because they're masses, they're big masses, and sometimes there's even multiple. Okay. Now, fibroids are benign tumors, basically, or growths of myometrium. Okay. So, grossly, you'll have these whorled pattern of just myometrial tissue. And same thing on histology, spindle cells, basically whorled appearance, and they're all uniform. Now, leiomyoma or fibroid is estrogen responsive, so it increases in size or the severity with estrogen in the menstrual cycle or excess estrogen as well. And that's pretty much the basis of a fibroid. Another important thing is there is something genetic in it. What's the gene involved in fibroids? If you guys know fibroids or leiomyoma and the cancer counterpart. Do you guys know? Okay. So the gene that's involved in both fibroid and the next disease that we'll talk about is MED12, MED12. Just remember that, okay? So this is a leiomyoma or a fibroid. Now, for a leiomyoma or fibroid, there's many locations depending on the location in the uterine walls. So you have, for example, submucosal, right under the mucosa, serosa, okay? Then you have intramural, such as in the muscular walls. And then you have subserosal pedunculated, and then you have, such as this one, pedunculated inside the uterus, okay? Do you guys need to remember all of this? I don't think so, but just know that there is many different ways a fibroid can form, okay? Or fibroid can present as. Now, how about this patient? What do they have? Good. This is a leiomyosarcoma. Good. Is a leiomyosarcoma related to a fibroid or a leiomyoma? Or can a leiomyoma form a leiomyosarcoma? Yes or no? No. Excellent. That's it. You need to remember that's not related. Okay. This is a very rare cancer of a myometrium, and it's not related to leiomyoma, okay, or a fibroid. It happens on its own, and the gene that's associated is MED12. Okay. That's very much leiomyosarcoma that you need to remember. Okay. Now, someone complaining of just abnormal uterine bleeding, you do a hysteroscopy and you see this polyp. Excellent. Okay. That's pretty much all you need to remember about a polyp. Its response to estrogen as well, and things like, for example, tamoxifen, estrogen, basically, uh, will increase is associated with polyps. Okay. So this is endometrial polyp. Whoops. Now, you have this patient, I'm gonna just give you postmenopausal, has been taking estrogen pills and is obese and complains to you of abnormal uterine bleeding. You do transvaginal ultrasound and you see an endometrial thickness more than 5 millimeters, around 10. Endometrial hyperplasia, excellent, okay? Which is increase in size of the endometrium. This is very important to remember how I just described it, or how the patient may be presented. Abnormal uterine bleeding being spotting. They're not supposed to have spotting because they're postmenopausal, so they see this and be like, oh, something's wrong. Um, Usually in a high estrogen state, such as taking OCPs, early menarche, late menopause, and nulliparity. Nulliparity means that they haven't given birth. Why is nulliparity involved? Is because of estrogen. They have more menstrual cycles, more estrogen. Okay, because during pregnancy there is progesterone that's maintaining it and so on. Okay, so that's that and other pathologies such as PCOS and other things that we'll talk about later on. Okay, so high estrogen. This will cause endometrial hyperplasia because there's no progesterone now that will basically cause it, or no cutoff of progesterone after progesterone increases, and this won't shed off this endometrium. So it keeps on proliferating and growing because of just unopposed estrogen. Okay. So with these patients, you need to take biopsies or you need to monitor these patients. Okay. Now, this patient, same patient, what do you see on biopsy? Hyperplasia. Okay, same exact patient. Do you see atypia in this case? No. Okay. So how do you want to manage a patient with endometrial hyperplasia with no atypia? What can you give to this patient as a drug? Again, they have unopposed estrogen. So what do you give? What's the hormone with other than no? What's the other hormone that's always with estrogen? Progesterone. Exactly. You give progesterone or progestin only OCPs. Okay, you give progestin because they have unopposed estrogen. So you want to give progesterone to get rid of that. Okay, and they usually, when they're taking progesterone, they have certain days that they cut off. So you have shedding of the, or combine OCPs. You have certain days where it sheds off, and then you give it again. Okay, you're just basically removing this unopposed estrogen. Give progesterone. Okay, that's pretty much how you manage this patient. If they have this, now this is endometrial hyperplasia again. Does it have atypia? Yes or no? Such as all of these cells, bad looking cells. Yes, good. So in this case, do you just give progesterone? No, exactly, surgery. What is a surgery? Transabdominal hysterectomy with bilateral salpingo-oophorectomy. Okay, which is basically remove the whole uterus with fallopian tubes and the ovaries because they're postmenopausal. Okay, so this is basically it. This is the surgical management. How about this patient? Very ugly looking tumor, mass, hemorrhagic, invading the basement membrane, full on endometrial carcinoma. Again, This is because of hyperplasia usually. There are a different, there's two different types, and I'll talk about this in a second. But again, management of this, it depends on the invasion, depends on the staging, but usually the only thing you need to remember is surgery, hysterectomy, okay? Now, for the two types. Now, in terms of the morphology, what is type 1 usually? Morphology or the cells itself? Description. Type 1 is endometrioid, type 2 is serous, okay? Type 1 is the one that's basically hyperplasia, then you have without atypia, then cancer. It's going to be endometrioid. Type 2 is serous, not related to endometrial hyperplasia. So, in that case, and type 1, is it related to estrogen? Yes or no? Good. Okay, yes. Type 2, is it related? Yes or no? No, good. Now, another thing is just the grade. Type 1 is a lower grade, type 2 is higher grade. Now, genes. Give me the most important gene for type 1. P10, good. Can you give me 3 more genes? Just throw anything. Okay, I'm going to save you that trouble, but please memorize at least 4. Okay? KRAS, good. Here's the 4. The most important is P10. Okay, that's why it's bolded. Just memorize 4 because we got this last year. Mentioned 4 genes in the SAQ. So anyways, PI3 kinase, KRAS, and then fibroblast growth factor 2. Okay, these are 4. Here you go. Memorize these. Okay, the most important one is P10 in case you get an MCQ. Okay, now what's the most important gene in type 2? Okay, good. P53. Here's another 3 others. PI3 kinase, CH3, and a bunch of letters. Again, memorize 4. Okay, so that's basically endometrial carcinoma in a nutshell. Now, in terms of the staging, it's very important. However, I don't think you guys really asked about staging because it's a bit advanced. But to give you guys simple, type 1, if it's in the uterus, does not go anywhere else. Type 2, if it goes to the cervix. Type 3 is if it goes outside of the uterus, but does not leave the reproductive organ or the true pelvis. And then 4, stage 4, is it goes beyond the true pelvis or and goes everywhere else, such as the abdominal cavity and so on. Okay? So type 1 stays in the uterus. Type 2 goes to the cervix. Type 3 leaves the cervix, goes to the vagina, or leaves the uterus, goes to fallopian tubes, ovaries, and so on. Type 4 goes far away. Okay? Just a quick way to remember. We're done with the uterus. Let's go now to the vulvovaginal disorders and anatomy. The most important thing to remember, 2 important high-yield things about the normal anatomy. Firstly, is this whole area is somatically innervated. So usually they'll come with severe pain. Okay, any diseases in this area. Number 2 are these glands. These glands are called Bartholin gland. Now, these Bartholin glands can be obstructed by anything, and it can cause a cyst or an abscess. So Bartholin's abscess or Bartholin cyst. And this is usually painful and it'll show up similarly to whatever this is. What is this? This is a cyst, or this is the pathology. Bartholin cyst, okay? Just memorize this image, very poor quality, so I hope you don't get this exact one in the image and get something a bit more clear. But usually it's very clear. It's one singular big mass that's usually red in color. And it basically presents with heaviness in that area and fullness. And sometimes we'll have discharge if it's infected with an abscess. Okay. Now we have 2 important diseases. This patient is a postmenopausal woman and complains to you of scaliness of the yeah, scaliness of the skin. This is lichen sclerosus. Excellent. Okay. Now, lichen sclerosus is due to atrophy, usually. So what do you see? Hyperkeratosis. Sorry, not this. Hyperkeratosis with epidermal atrophy. Important feature is this. Do you see any red tape pegs? Yes or no? Exactly. Loss of red tape pegs. No, no red tape pegs, lichen sclerosis. That's pretty important. And you have some lymphatic, not lymphatic, lymphocyte or lymphocytic infiltration, so on happening over here. Most important thing is no red tape pegs. Okay. This has a risk of a certain cancer that we'll talk about later. Okay. How about this patient? Very itchy lesion that they keep scratching. And then it became very hyperkeratotic. Good. Simplex chronicus, lichen simplex chronicus. Again, it's because of chronic irritation that they keep itching the area, hence it becomes very scaly and gray. And you can see hyperkeratosis, increased thickness. And then do you see irritated pegs? Yes or no? Yes. Okay. That's pretty much lichen simplex chronicus. This is also a risk factor of a certain cancer that we'll talk about. Okay. Now, the most important virus or entity in reproductive is HPV. So HPV is a virus. It's double-stranded and circular. Okay. Now, this virus has many serotypes. Okay. The most important ones that I want you to remember, 6 and 11, then 16, 18. There's also 31 and 38. Okay. Or 33, sorry. Now, 6 and 11 causes warts. 16 and 18 causes cancer. Why 16 and 18? It produces two things. E6, I'm just going to draw a 6, much easier, and E7. E6 inhibits what to cause cancer? P53. Good. Okay. To remember this, 5, 6. Okay, immediately. Okay, P53, that 5 and P53 is inhibited by 6. Okay, something to remember. That's how I remember, honestly. 7 inhibits what? Retinoblastoma. Now, these two, P53 retinoblastoma, are tumors, basically surveillance in the cell cycle. So basically, checkpoint inhibitors, sorry. So basically, if you inhibit both of them, there's no more checkpoint inhibition, there's no more monitoring. Tumors will keep, or cells will keep dividing, gain mutations, not be sensed by these two. Okay? Hence why you have cancer with 16 and 18. The most important one is 16. However, they're usually together. 16 and 18 causes cancer, but usually it's 16 more associated with them. Okay? Other serotypes that cause cancer is 31, 33, and some other ones. Memorize these two. Okay? Again, 6 and 11 to cause warts. Now, what is seen in this patient? Okay? What is the change that's occurring here? What do we describe it as? Okay, that's a feature of what? Coilocytic changes. Good. Okay. Coilocytic changes. Now, what four findings do you see in coilocytic changes? First one you guys mentioned is perinuclear halo. What's three other? Nuclear hyperchromasia, one. Maybe two more. Enlargement, two. And irregular borders of the nucleus. Excellent. So to remember this, three nuclear, one around the nucleus. Okay. What's the three nuclear? Look at the nucleus. Is it big in size? Yes. It does have irregular borders? Yes. Is it darker? Yes. Three features. Hyperchromasia, increased size, and irregular borders. Three features. Look around the nucleus. That's a fourth feature. And it's a halo. So perinuclear halo. Yeah, these are all features of coilocytic changes. Now, where do you have HPV related? This is all HPV related, whether it's warts or cancer. And the cancer could be in the cervix or could be in the vulvar vagina. Okay. So you'll see this in all of the pathologies related to HPV, such as this patient. What do they have? Excellent. Condyloma acuminata or acuminatum. Okay, good. This is a wart, and you can see this verrucated, fungating, basically look, and this is basically the condyloma or the wart itself. What do you see in these two images in the wart? Same thing we just described. Just give me the change that's occurring. Polycystic change. Okay, so this is all features of HPV. What serotypes of HPV causes condyloma acuminatum? What serotypes? 6 and 11. Excellent. Memorize these two, and it causes warts. Okay. Now, how about this patient? What's happening to them? It's not a wart, but it's something. Good. VIN or vulvar intraepithelial neoplasia. Okay. This is basically leukoplakia that's happening, the whiteness that's happening in the vulva or the labia. And then here you can see coilocytic changes, okay, with atypia that's happening all throughout the the what's it called, the size of the tissue epithelium. Another thing to remember is it's not invading the basement membrane. Okay, so that's why it's intraepithelial neoplasia. Okay. Now, how about this patient? What do they have? Invasive vulvar carcinoma. Good. Now, invasive vulvar carcinoma is separated into two types based on HPV related, not HPV related. Then it's divided three types based on morphology, and then the one separate one that's HPV not related. These two, are they HPV related? Yes or no? Yes. Okay. Now, what are these? First of all, this is where the basement membrane is supposed to be, and the cells are close to the basement membrane. So what do we call this type of invasive carcinoma? Basaloid. Excellent. Now this one, just memorize, it looks warty. So I'm just gonna say it's a warty. It's a warty subtype. Okay. Most important thing, invasive ovarian carcinoma is divided to two. HPV related, not HPV related. Then the HPV related subdivided into two more, basaloid and warty. Okay, so these two are HPV related. So you might see in the VIN stages that they have coilocytic changes. How about this patient? This patient in the past, good. This patient in the past had lichen sclerosis and then developed this. Okay, so this is differentiated vulvar intraepithelial neoplasia and it's squamous cell. Okay, now the squamous cell variant, is this HPV related? Yes or no? No, it is not. It's related to lichen sclerosis and lichen simplex chronicus. Okay, it leads to squamous variant, which then leads to this. What's happening here? We've seen this feature of all of this so many times. Squamous cell carcinoma, exactly, of the vulva. All right. This is not related to HPV. This is related to lichen simplex, or sorry, lichen sclerosis and lichen simplex chronicus. Okay. Because of the chronic irritation and so on, it's going to cause squamous cell carcinoma. Okay. Remember these two differences in terms of HPV related, not HPV related. Okay. How about this patient? Not cancer. It's a tumor, kind of, but something else. Papillary hydradenomas. Good. There's nothing really significant to know about this one, other than just memorize this image. Okay. It has two layers similar to the breast. It has the epithelial cell and then myoepithelial cell. So it looks like a salivary gland, and it's basically what it is. Okay. That's pretty much all you need to remember about it, and just memorize this image. Okay. Now, you have a patient who comes to you with, I'm just gonna say, a lesion in the vulva that is scaly, uh, kind of red to very dark brown lesion that might be a bit bloody. What's your differential here? extramammary Paget's disease. What's another differential that you want to have with it? Melanoma. Excellent. Good. They look very similar on gross image of like the lesion itself. You won't be getting the image itself, so don't worry about that. It's very similar in terms of the histology as well. Okay, so there's one way you can differentiate them through immunohistochemical staining. Okay, so what is Paget's disease? We'll talk about this in the breast, but basically it's a tumor that has metaplastic cells in the epithelium. Okay, that's pretty much it. It's basically hidden. That's why it's called Paget's disease. Okay, this is extramammary in the vulva. Okay, now very important thing is you want to stain this using immunohistochemical staining. What marker do you use for Paget's disease? Cytokeratin. Excellent. What will be negative in Paget's disease? What markers? S100 and one more. Give me one. HMB. Excellent. Good. How about this patient? What do they have? Melanoma. What staining or markers would you use? S100 and HMB45. Good. That's it. That's all you need to remember for this diseases. You will get this in MCQ. More than 100% you will get these two, and it will tell you HMB positive, what is the disease, or cytokeratin positive, S100 negative, what is the disease, and you'll know. Okay? Memorize these markers. That's very much those. Now, you have a female patient that comes to you with, can I say, abnormal vaginal bleeding, and they tell you when you take history that during one of their pregnancies, they took diethylstilbestrol and they developed this. What is this disease? Go one step back. Wait. Yes. Vaginal adenosis, not carcinoma, adenosis. Okay. Vaginal adenosis, what is adenosis? It's basically the vagina. Does it have glands typically? No. Okay. So what happens is there's glands that form, which is all of this. Okay. All of these things that are forming. Okay. What's the lining of the vagina? Just like that to cervix, squamous cell. Does it have glands? No, typically. Small little glands here and there, but not like this. Adenosis, where you have redness all over the vagina and the ectocervix over here. This is because of exposure to DES, diethylstilbestrol, causes vaginal adenosis. This is high yield because in the question itself, you will get exposure to DES. Okay, what is the disease? Most likely vaginal adenosis. Now, vaginal adenosis can lead to cancer, which is this one. What cancer is this? Clear cell carcinoma. Excellent. So there's a clear cell carcinoma because of diethylstilbestrol, because of an adenosis. Okay. Tamam. How about this patient? They have a grape-like mass. It's in the vulva. And I gave you the rhabdomyosarcoma. Good. Okay. Rhabdomyosarcoma, grape-like features. Just memorize this image. Okay. The gross image, because that's the diagnostic, or that's the characteristic. And then in terms of the pathology, it would be positive for muscular staining for IHC. Okay. Now, you have a patient that comes to you with severe, painful, itchy lesions in the vulva. Herpes. What serotype in the genital? 2. How about 1? Where does it, HSV1, where does it cause? Oral, typically. Good. Can it interchange? Yes, it can, because of poor practices. Okay. Keyword is painful. Okay. Painful, itchy, multiple vesicles. Okay. That's pretty much HSV for you. Now, how do you want to diagnose it? Give me one method of diagnosing HSV. PCR, good. That's one of the most important. Can you do staining or smearing? Yes, Zank smear, which is what this is. What do you see on Zank smear? Giant cell, good. So this is a Zank test, which shows you multinucleated giant cell, good, which is this. So this is HSV. Now you have this patient who has an ulcer that's located in multiple areas, but usually a genital ulcer. Good, syphilis. Okay, what's the organism causing syphilis? Treponema pallidum. Good. This is primary syphilis, okay, which causes the genital ulcer. Okay, syphilis has multiple stages or multiple, primary, secondary, latent, tertiary. Okay, primary syphilis is when you have these genital ulcers. Okay, now treponema pallidum, what type of organism is it? Spirochete. Good. Okay, perfect. How about this patient? What did they develop? Had an ulcer before, then a few weeks later it presented like this. Secondary syphilis, good. Which presents as ulcers everywhere. And very important to remember is it's symmetric, okay? So one side will have it and the other side will have it, okay? This is very important. Symmetric ulcers, okay? This is secondary syphilis. Usually happens in patients who didn't treat primary syphilis and patients who are immunocompromised, okay? So that's that. Then the secondary syphilis can go to latency, then turns into this very bad disease, which is what? Tertiary, which is basically a bunch of gummas, which is this necrotic inflammatory tissue that's everywhere in the body. Okay, that's tertiary syphilis. Okay, now this is basically what is the organism showing you here? Treponema pallidum, good, which is a spirochete, and you need to do dark microscopy. Okay, this is treponema pallidum. Now, in terms of the testings that you can do, you need to remember these two. Number one is NTT, which is non-treponemal testing, and number two is treponemal testing. Okay, TT. NTT, there's two parts of it. There's VDRL and then RPR, which is what's showing you in this picture. One of the most, actually, I'll ask you guys in a bit. Then treponema testing would look for hemagglutination. Which of these two can you use to monitor treatment? NTT or TT? If someone's being NTT, good. Okay. NTT is what's used for monitoring patients who are being treated for syphilis. Okay. Why? TT will remain high. Okay. If they're being treated, it'll still be high. Nothing will change. That's why you use NTT to monitor patients who are being treated. Now, you have this patient who has a very painful ulcer. Painful. Good. Haemophilus ducrei, which causes, what's the disease name? Crancoids. Okay, crancoids. I can never pronounce it. But anyways, what do you see on this imaging? School of fish or the railroad appearance. Good. School of fish appearance or railroad appearance. Both of them work. Okay. This is a very important image for your OSPE. Okay. Haemophilus ducrei causes cancoid. This patient has a painless bleeding ulcer and painful lymphadenopathy. Okay. Okay. So this is Klebsiella, good. Granulomatous, which causes granuloma inguinale. Okay. Painless bleeding. Okay. That's the key word. Okay. That's what you'll get in this step. Painless bleeding with painful lymphadenopathy sometimes. Okay. Or painful lymph node. When you try to diagnose it, you see this. What do you see here? Good. So still, Klebsiella granulomatous, you can see Donovan bodies, which are these pin drop cells or safety pin appearance, okay, of the organisms. Okay, and this is the Donovan body with a bunch of these organisms inside, which is the pin drop appearance of the organism. Okay, this image is also very high yield. Okay, so that's this. Now you have this patient who presents to you with this ulceration with a lymphadenopathy. Chlamydia, excellent. Which serotypes of chlamydia? L1, L2, L3. Excellent. Okay. These are the serotypes that causes these ulcerations because there's another chlamydia disease that's a different serotype, that's something else. This is also called lymphogranuloma venereum. Okay. This is chlamydia. Now when you so yeah, this is basically chlamydia. Now this patient, different patient, comes with discharge that is purulent and white. Gonorrhea, caused by Neisseria gonorrhea. I said in the previous part of the crash course that Neisseria gonorrhea causes Waterhouse Frederick's. It's not, it's Neisseria meningitidis. Neisseria gonorrhea causes whatever this is, which is urethritis, okay? And this is basically the white, purulent discharge. Now, when you're trying to diagnose, what is this organism that's showing you? This is the same patient, Neisseria, gram-negative diplococci. What is the media that you use to culture Neisseria gonorrhea in? Thayer Martin. Another name of Thayer Martin is VPN agar. Okay, so this is Thayer Martin for Neisseria gonorrhea. Okay, which is basically chocolate agar with antibiotics such as vancomycin, thiocyanates, and some other stuff. Okay. Now, what happened to this baby who their mother had Neisseria gonorrhea? Vertical transmission. What do you call this? Ophthalma neonatal. Good. Excellent. Because of gonorrhea. How do you treat this patient? Do you know the drug that we give? Ceftriaxone. Excellent. And you give it topical for these patients. For Neisseria, usually gonorrhea or urethritis, which is this, you give them IM, intramuscular ceftriaxone, and you give them something else as well with it, which is azithromycin or doxycycline. Okay. How about this patient? What do they have? It's not purulent. Chlamydia, excellent. What serotypes of chlamydia causes discharge and urethritis? D to K, okay? So chlamydia, D to K, okay? These are the serotypes that causes urethritis, okay? Now, important thing to remember is Neisseria and chlamydia infections are risk factors for something called pelvic inflammatory disease, okay? This is a chronic disease, happens late. And the important thing about pelvic inflammatory disease is it's a risk factor for ectopic pregnancy, okay? Just memorize this sequence. Chlamydia and Neisseria, if it's not treated, causes pelvic inflammatory disease. Pelvic inflammatory disease is a major risk factor of ectopic pregnancy. Okay, something to remember. And it's usually in a scenario of an ectopic pregnancy, someone who's had infection or has multiple sexual partners. Okay, so that's pretty much that. Now, what is the diagnosis of this patient's biopsy and chemical testing? Chlamydia. What do you see in this image? This is a high yield image. Iodine stain showing you what? McCoy cells. Good. Chlamydia trachomatis. This image is high yield. Ignore these two. Okay. This. That's it. We're done here. Now, you have this patient who comes to you with a green discharge that is sometimes fishy colored, a fishy smell to it. Good. Trichomoniasis. Excellent. What do we call this appearance of the cervix? Strawberry cervix. What feature does the organism have when you visualize it? Important feature. Flagellated, which moves. Excellent, that's it. Green discharge, exactly, wobbling. Green discharge, sometimes fishy, but just very bad odor. Strawberry cervix, and then motility, okay? Trichomonas vaginalis. This patient had taken antibiotics and had performed vaginal douching, okay? Then presented to you with this. Bacterial vaginosis, good. Bacterial vaginosis, what's the main organism causing it? Gardnerella vaginalis, good. What organism is the predominant organism in the vagina normally? Lactobacillus. When you do douching, for example, or give antibiotics or immunosuppressed, this will reduce lactobacillus, so something else will grow. Similar to C. diff in the GI. Similar concept, okay? Something goes down, something else will go up, okay? Because that's how bacteria is. So this is Gardnerella vaginalis. What do you see on this image? Clue cells, good, okay? Which is basically the Gardnerella vaginalis around epithelial cells. Now, when you do this, which is KOH staining, what is characteristic of this? What will happen? There is a specific smell that will happen. Fishy smell, okay? This is kind of characteristic for Gardnerella vaginalis or bacterial vaginosis, okay? So, this patient is immunocompromised, is taking steroids and took antibiotics, and then you see cottage cheese discharge. Candida, good. And we all know Candida very well, okay? This is from the cervix, this image from the cervical lecture, but it's basically still any candidiasis, similar concept, okay? We're done with the vulvovaginal diseases. Now let's go to the cervical diseases. Number main organism, HPV. Now we go. HPV in the cervix, specifically in the transformation zone, can cause metaplastic changes. What are these changes? Firstly, broadly, give me what is happening in the cervix here. What's the diagnosis of all three of them? Cervical intraepithelial neoplasia. Is there invasion to basement membrane on any of this? Yes or no? No, good. Now, cervical intraepithelial neoplasia, we can divide it to low grade or high grade, or we can differentiate it into SIN 1, SIN 2, SIN 3, okay? How do we do this? As we look at the thickness. This patient, this first one, image B, has metaplastic changes in the lower 1/3 only of the epithelium. What stage do we put them as, or grade? Stage 1. Good. This patient has the metaplastic changes in the 2/3 of the epithelial thickness. What stage is this? Stage 2. This patient in the full thickness, stage 3. Good. So these are the stages. SIN 1, lower 1/3. Stage 2, 2/3. Stage 3, full thickness. If we want to say grade, we need to do something before we say this is grade. How do we grade it? What do we need to do for like to take samples? How do we take samples? If you guys know, I don't know if I said that correctly. Pap smear, excellent, good. So you do pap smear and you see cytology. And based on that cytology, you can see if something is low grade versus high grade, which is through this. So you do a pap smear and you see the cells, and you can assess the grade into low grade versus high grade, okay? Now, to make it easy, I'm going to use the same stages, SIN 1, stage 2, SIN 3, and so on. This is normal. The nucleus is small, the cytoplasm is big. How about this patient? Is it SIN 1, 2, or 3? 1, good. Is it low grade or high grade? Low grade, excellent. This patient had an increased NC ratio. Is it SIN 1, 2, or 3? 2. Is it low or high grade? High grade, excellent, good. This one, very increased NC ratio. 3, high grade, okay? To explain, look at the nucleus here. It's way bigger than normal, but the cytoplasm is still big. Hence, we say this is SIN 1 or low grade. Here, the nucleus is much bigger. However, the cytoplasm is still present. There's still, the NC ratio is still high. However, it's not as high as this. This patient You can barely see the cytoplasm. The nucleus is so big. Hence, we say this is sin 3, very high grade or high grade, and this patient has sin 2. Okay? That's pretty much these. Know this image. These two, both of them. Okay? How to differentiate them very, very well. Okay? Now, what happens? What happened to this patient? Carcinoma, invasion, carcinoma. Good. Now, something to remember, guys, is how does cervical cancer appear as? Either cervical intraepithelial neoplasia or cancer. Obviously, cancer will have weight loss and so on. But the important clinical feature is something called postcoital bleeding. Bleeding after intercourse. Okay? This is very characteristic. Okay? Or it's found incidentally. You do screening pap smears and you find it. Okay? Through doing the cytology. So this cervical squamous cell carcinoma, because you can see all the keratin pearls, and this is showing invasion into the basement membrane, okay? And this is the mass itself in the cervix, okay? We're basically done with the cervix. Another thing important to remember is the grading. Sorry, the staging in terms of the locations, because stage 1, if it's confined to the cervix, stage 2 is it expands beyond the cervix, however, it does not go to the lower vagina. Stage 3 goes to the lower vagina. Stage 4 goes everywhere else. Okay, that's basically the staging of cervical cancer, and the treatment is obviously surgical mostly. Okay, so now we go to this. You start talking about the ovaries. What does this patient have? Normal ovaries. Good. These are normal ovaries. Okay, I didn't give you a scenario of the next disease. Um, Normal patient. There are normal amounts of follicles. I think it's around 10. I could be mistaken in this case. Follicles are normal, and then you can see this big follicle, which is basically a Graafian follicle about to ovulate. Okay, but this is all normal. If you see so many, much more than this, and you'll see in the next picture, this is another diagnosis. Okay, please remember these two images because we got it last time, and a lot of people got confused with this. And they said it's another disease, which is whatever this thing is. You have this patient. Yep. You have this patient. Let me finish the scenario play. You have a patient who presents to you is very obese, hair growing, mustache, virilization. What is it? PCOS. Good. Now, PCOS is polycystic ovarian syndrome. Okay. There's many cysts in the ovary. Many more. This is way more than 10. It's so many ovaries. So many cysts. Okay. So this is PCOS. How do you diagnose PCOS? Firstly, what's one lab value that you look at? One lab value. LH. Excellent. LH will be more than FSH. Okay, this ratio. Another thing is, what's another lab value that you want to look at? Androgens. Excellent. Testosterone. Usually, how it's diagnosed is evidence of hyperandrogenism, then or like clinical features of it, such as virilization. Then you have oligomenorrhea as another part of the criteria. Laboratory evidence as well with the LH-FSH, and then lastly is imaging findings. Okay, so this is how you diagnose PCOS. Now, PCOS, uh, I think it's related to to differentiate this from a follicular cyst. I doubt you will be asked to do this because that is very advanced, not gonna lie with you. But I think it's related to the days of menstrual cycle. If this is, for example, day 13, right before ovulation, when you see this, the next day it's gone, you can say this is a Graafian follicle, a Graafian cyst. But I really doubt they ask to differentiate. Plus, it wasn't in the slides for radiology that's high yield. Okay, so that's PCOS. Important thing about PCOS causes amenorrhea or oligomenorrhea. Uh, Another thing is it's high estrogen state, so it causes all the estrogen related diseases that we talked about. Another thing is Metabolic diseases, such as what? What's the most important metabolic diseases that these patients have? Diabetes, good. So how can you treat these patients generally? PCOS, metformin, good, and lifestyle modifications. Then we have certain drugs for PCOS that we'll talk about later. So now we're gonna talk about ovarian cancer, okay, and ovarian tumors and so on. As I said, three main cell types: surface epithelial cells, germ cell, and then sex cord and stromal cells. The most common type is surface epithelial cells. From it, serous is the most common type, okay? And we'll have a lot of other ones that's under it, and we'll talk about each one in the next slides. Then we have germ cells. Then we have, which typically affects the younger age groups, because if you think about it, germ cells, embryo, young age, so all the young age ones. And then we have all ages, which is all of these. However, these have specific symptoms that it causes, and it's very easy to remember, and I'll let you guys know on that, okay? These, you need to know how to differentiate it histologically, as well as these. And then this and this one for imaging, and then these based on lab and symptoms that I want you guys to differentiate. Let's talk about them one by one. First one, benign thing that's happening with this patient. Very benign. Good. Follicular cyst. Okay. It's not really high yield to remember this. However, remember the image, okay, which is follicular cyst. Okay. How about this patient? Big yellow cyst, luteal cyst, okay? And the kind of important thing to remember is it is associated with a certain disease. Do you guys know what disease it's associated with? Usually you'll find corpus luteal cyst with this disease. Not granulosa tumor, no. The trophoblastic disease, the gestational trophoblastic disease, the moles. Sometimes you'll find corpus luteal cyst with it, okay? That's pretty much the association that it has. I don't know if it was mentioned to you guys. However, for those of you starting OB-GYN next year, this is important, okay? Now, what does this patient have? Adenocarcinoma. Good. I think I've seen one patient with ovarian adenocarcinoma and their abdomen was huge. It was very big, okay? It's a very bad tumor in terms of like the symptoms and stuff it causes. So we'll talk about each one, okay? And we'll talk about its complications, okay? Which one important complication. Now we'll talk about them. What is this? Excellent. Serous cystadenoma, that's benign. It's secreting serous fluid, okay? Columnar cells secreting serous fluid. Again, serous is darker than mucinous in terms of the color on histology. So when we go to mucinous, it'll look much lighter than this. And this is serous. So there's a lot of fluid that's accumulating in it. So this is ovaries, ovarian cyst. If you remember from the pancreas and GI, or I think it was a pancreas, we talked about serous tumor and mucinous. We're going to talk about the exact same here, okay? So this is serous cystadenoma. Benign. How about this patient? Borderline serous. Excellent. Good. So this is borderline serous cystadenoma, okay? Borderline or tumor. Borderline in terms of we don't know if it's benign or malignant. It could go either ways, okay? So we say it's borderline. It's about to be malignant, for example, which is then what happened to this patient? Serous cystadenocarbonoma. Good. Invasion of basement membrane, usually carcinoma is bloody, hemorrhagic, large tumors. And then you see this finding. What is this finding? Psammoma bodies. Usually, guys, papillary tumors or papillary carcinomas will have psammoma bodies. Just something to remember. Okay. So serous adenocarcinoma. Okay. So that's pretty much this. How about this patient? Mucinous, benign. Good. Mucinous cystadenoma. Again, you can see all the mucin. Okay, white, lighter in color than the serous one. And you don't have serous fluid over here. Okay. Now, this image and the one for serous, you will get a question on it. Okay, so memorize these two images: serous cystadenoma and mucinous cystadenoma. Yes, I think so. Okay. How about this? Good, excellent. Mucinous adenocarcinoma. Okay, and its papillary appearance. However, I don't see any small bodies in this picture. And just remember, small bodies for the serous one. Don't remember for this. And it's just a mucinous variant. It's carcinoma. Important thing about these ovarian tumors is it spreads. Where is it spreading in this case? Peritoneum. So what do I call this disease? I'll talk about that appendix later. This is called pseudomyxoma peritonei. Another name for it is a mental caking. Okay? It cakes, exactly. It cakes into the omentum, spreads through the omentum, and goes somewhere else. Now, something very important is in pseudomyxoma peritonei. If you have one ovary involved, this means it's most likely from the ovary. If it's both ovaries involved with the pseudomyxoma peritonei, it means something else is spreading through the peritoneum and going to the ovaries. Most commonly is appendix. Excellent. Okay. So appendiceal tumors, if it spreads through the peritoneum, causes pseudomyxoma peritonei, it goes to both ovaries. Okay. If it's ovarian cancer that's causing pseudomyxoma peritonei, it will be one ovary involved. Okay. So that's pseudomyxoma peritonei for you. How about this patient? No. Endometrial. Excellent. These are all glands, stroma of the endometrium that's cancerous. Okay. That's it. Endometrial tumor. It's spread to the ovaries. Okay. That's very much this tumor. How about this tumor? Good. Cystadenofibro. Okay. Another tumor of the linings. All right. In terms of high yield and what to remember for this, I'll say not much, okay, to remember from these. Now, before I move on, what's an important marker for ovarian tumors, usually? Good. CA 125. Excellent. All right, just remember that for markers of ovarian tumors. How about this patient? This is an important one. What ovarian tumor do they have? Brenner's tumor. What cell is lining Brenner's tumor or causing tumor? Transitional cell. Urothelium. Excellent. So bladder epithelium, urothelium, transitional epithelium. This is what you see on Brenner's tumor. This is going to be given to you as a description usually. Okay. Patient, abdominal distension. You think of ovarian tumor, they tell you it's lined or it's formed by transitional epithelium. What tumor is it? Brenner. Okay. Or they ask you, what is the cell causing Brenner's tumor? Transitional cell. Okay. This is Brenner's tumor. What do you see on these two images? Good. Another name for that. Mature teratoma, good. Or dermoid cyst, good. Now we'll talk about this in a bit, but memorize this image for teratoma because it's much more clear, okay? You can see calcification and then a bunch of different types of tissues, okay? Hence, mature teratoma. How about this patient? Same patient. Well, progressed maybe or same disease, okay? Teratoma. How do I know this is teratoma? Again, different. Once you see calcification in a tumor like this with a bunch of different types of masses or types of tissue, teratoma, okay? This is a variant teratoma. That's a mature teratoma. Now, teratomas, there's two types, mature and immature. Which one is more malignant? Immature, good. Mature teratoma is usually less, okay? What do I see here? What does this patient have? Mature teratoma. You'll see three cell lines. Endoderm, ectoderm, mesoderm. All three. So you'll say most commonly what they describe it to you, they will have hair, they will have teeth, they will have glands, muscle, okay? Or and epithelial cells. All cell lines, okay? That is a mature teratoma. Now, one form of teratoma, or wait one sec. Okay, my bad. Is this what tumor does this patient have? Stroma ovarii. Now, stroma ovarii, what important hormone? Good. Thyroid hormone. Good. So you have a bunch of thyroid follicles. Okay. That's it. This patient has bronchospasm, has right-sided heart disease, and has diarrhea. What tumor do they have? Carcinoid. Good. Okay. What does it secrete? Serotonin. Excellent. Okay. This is carcinoid tumor. Now, this patient has what? And what's the cell causing it? Or what cell line is it from, typically? It's a tumor of one cell line, and it's very malignant. This is immature teratoma, caused by what type of tissue, usually? Neuroectoderm tissue, okay? That's all you need to remember. Immature teratoma is much more malignant than mature teratoma, and it's usually formed by neuroectoderm tissue. Okay, that's it for this type of tumor. Now we go into the other germ cell tumors. What does this patient have? This is the exact same as a male seminoma. Dysgerminoma, excellent, good. Now, what receptor marker is it positive for? Getting different answers, but it's c-KIT, good. So dysgerminoma, the marker that's positive for it is c-KIT, and please remember c-KIT, please, okay? Please, for dysgerminoma. This is very similar to male seminoma, okay? So yeah, that's pretty much it for dysgerminoma. How about this patient? Yolk sac tumor. What do you see on histology? What's this feature called? Schiller-Duval bodies. Excellent. It's a very yellow tumor with Schiller-Duval bodies. Now, what will be positive in these patients? What marker? Alpha-fetoprotein. Excellent. Good. Okay. This is endodermal sinus yolk sac tumor. This patient has this. What do they have? Choriocarcinoma. Excellent. What will be positive and high in these patients? What lab investigation? Yes, beta HCG. Good. This will secrete beta HCG. Why? Choriocarcinoma is a tumor of syncytial trophoblast and cytotrophoblast. What do they secrete? Beta HCG. Okay. Now, something very important to remember. Choriocarcinoma happens from two different pathologies in this block, or usually. Number one is what you, okay, and the balloons is happening again. Number one is this, which is the ovary. And number two is molar pregnancy. Where does this tumor spread to? Typically, the lungs. Excellent. Good. This tumor loves to spread to the lungs. Okay. That's, yeah, just something important to remember about this choriocarcinoma. Now, I don't know if this was mentioned to you guys, however, it is worth noting is choriocarcinoma. If it happens from the molar pregnancy, it has a good prognosis. If it happens from a primary ovarian tumor, such as this, it has bad prognosis. Okay? That's something to remember about choriocarcinoma. Oops. How about this patient? Now we're going to the stromal tumors and the sex cord tumors. Let's just say this patient has, okay, good, granulosa tumor, excellent. Okay, granulosa tumor. What do you see on this? What do we call this feature? Call external body, excellent. What hormone does this tumor secrete? Estrogen. So usually patients will have endometrial hyperplasia, okay, because of the estrogen, unopposed estrogen. So usually if they ask you, someone has endometrial hyperplasia, has an ovarian tumor, what ovarian tumor is that? Granulosa cell, okay? That's typically how it's described in question stems. Okay, and then what feature, maybe they ask you, what feature do you see on histology? Call external body. How about this patient? Good. Sertoli-Leydig tumor. Good. Now, for this type of tumor, what do they secrete? Androgens. Excellent. So they'll have virilization. Okay. Hair. That's typically how it's described in the question stem. If someone has virilization, this is Sertoli-Leydig. If someone has high estrogen and endometrial hyperplasia, this is granulosa. Okay. Now, the last thing in gynae, and actually this is much faster than I thought, is drugs. Now, in terms of the treatment of a lot of these diseases is OCPs, okay, so which is a major drug in all of this block, okay? One of the major ones. Now, another thing is if you want to induce ovulation, okay? Now, if someone has primary amenorrhea and someone has, like, for example, low GnRH, for example, what's it called? Immature hypothalamus, and there's this disease that's characterized by that. I forgot what it was called. So anyways, you give GnRH. That's pretty much simple. If someone has a poor functioning hypothalamus that's not secreting GnRH, you give GnRH, and that fixes everything. Which is in the form of gozerelin, or in your lecture is I forgot actually what it was called. So anyways, then you have leuprolide. Okay. Gonadorelin, that was the drug. The GnRH analog. Okay, so that's how you replace GnRH. Then you have someone, for example, with PCOS. With PCOS, what drug do you want to give? Two drugs that you can give. Other than metformin, good, excellent though. To induce ovulation, other than OCPs, you can give letrozole. Another drug that you can give, clomiphene citrate. Good. Now, clomiphene citrate, it will act on the hypothalamus. How does it do that? It basically binds to estrogen receptors. When it binds to estrogen receptors, the hypothalamus is going to be like, oh, I'm getting estrogen is not binding to me anymore, and it's just clomiphene. So what am I going to do? I'm going to increase GnRH. Then it increases LH-FSH, and mostly FSH in this case. This FSH will cause ovulation. Okay? This is how clomiphene works. Letrozole and other act on what enzyme? What does letrozole act on? Aromatase. It's an aromatase inhibitor. So aromatase basically is a drug that will get something and form estrogen, okay? Whether this is testosterone to estrogen, androstenedione to estrogen, or estrone or whatever. Okay, this is mostly found on adipose tissue. However, it can be also in ovarian tissue. Now, what is the concept behind this? Is you decrease estrogen. Why would you want to decrease estrogen? You have more positive feedback. Okay, GnRH will increase, LHFSH will increase, and you have ovulation. Okay, hence why you use aromatase inhibitor to induce ovulation. Okay, or if you want to, yeah, basically increase their ovulation. Okay, so that's pretty much these drugs. Important side effect of these drugs, clomiphene, GnRH analogs, is what? Because you're inducing ovulation. So what's an important side effect? Do you guys know? Excellent. Ovarian hyperstimulation syndrome. Okay, where it's basically forms many follicles, and that's pretty much that. Okay, so this is ovarian hyperstimulation because of you're inducing ovulation, and it's gonna grow multiple follicles at once. Okay, so that's pretty much these drugs. Now for the contraceptives. Okay, contraceptives, you have drugs, IUDs, implantable, or you also have patches, and then you have surgical. Okay, we'll talk about the drugs first. So hormonal, you have estrogen only, or mostly estrogen, actually never estrogen only, estrogen combined with progesterone, which is OCPs. Okay, and then you have progestin onlys. Now, how do these work? Is basically you cause a negative feedback. Okay, GnRH will go down, LHFSH go down, no ovulation. Okay, because you are giving estrogen. So what will this estrogen do? Negative feedback. Okay. Now, progestins have a different function as well, which it basically thickens the cervix, so and the mucus it synthesize, and this basically prevents sperm entry, and it thins the endometrium, so it's not going to be able to implant. Very important about these two drugs is in a patient with any endometrial hyperplasia or breast cancer, can you give combined OCPs? No, you usually never give them. Why? Because why would you give estrogen that's causing all of these diseases? So you usually give either progesterone only or you give other methods. Okay. Now, in terms of side effects of both of these drugs, cardiovascular diseases, stroke, MI, venous thromboembolism, and then obviously estrogen-related side effects, which is endometrial hyperplasia, endometrial cancer, breast cancer. There's many, okay, side effects. Then these are the most important ones to remember, okay? The next, and then also the hormonal contraceptives can be given also in a patch, which lasts a lot longer, and then a ring, which is not really too important. Then you have the IUDs, intrauterine devices. There's one that's copper-free, and then there's one that is hormonal, which is progesterone. Okay. Now the progesterone IUDs act just like the oral progestins. Okay, same mechanism. Copper IUD basically induces inflammation of the uterus. Okay, so this will basically make it very toxic that fertilization or sorry, implantation will never occur. And it's also toxic to the sperm and ova itself. Now, important thing about IUDs is it causes abnormal uterine bleeding, and this is more specifically with copper IUD, and that's a contraindication of giving an IUD if they have active bleeding. So you need to rule out the whatever is causing the bleeding, fix that, then you can give. Okay. Another important side effect of IUDs is it can cause ectopic pregnancy. Okay, usually in the fallopian tubes, because if you think about it, it's causing inflammation. So if you have implantation that's happening in the fallopian tubes, it's going to happen because there's something obstructing it. So yeah, so that's why it causes ectopic pregnancy. Okay, that's pretty much that. Surgical, you have two ways. For a male, it's a vasectomy. Females, it's tubal ligation. Okay, and that's pretty much irreversible. These are basically the contraceptives. For the hormonal, there's many types. I know that. And just go over Dr. Minal's lecture for this. Okay. Just read the different types of hormonal drugs. Okay. Uh, that's it for gynae. Part of repro. Do you guys have any questions for that part? Or is everything clear and we continue? Okay, perfect. So now that's the bulk of the section, by the way. Now we'll go over obstetrics and the breast. Okay. Obstetrics is pretty easy, and I'll basically mention everything from your clinical and your pathology and pharma lectures. Okay. So first thing is just basics of obstetrics. You have the placenta, and then you have the amniotic sac. Okay. Very important definition is amnion is anything towards the fetus. Okay. Chorion is towards the mother. Okay, or towards the placenta. That's pretty much it. Inside the placenta, you have two different types of cells, initially syncytial trophoblast and cytotrophoblast. That's pretty much it, all you need to remember from it, okay? An important thing is you will see villi in the placenta, okay? That's pretty much it for these, okay? There's nothing too much about the basics. Now, very important is terminology, okay? First thing is you have this system called GT-PAL, okay? First one is G, gravida, T, term, P, preterm, A, abortion, and then L for living. Gravida is total number of pregnancy, including the current one that the female is having, okay? So that's pretty much that. Term is number of pregnancies after the 36th week of gestation, okay? Usually the average number of weeks is around 38 weeks, okay? 37, 38 weeks. After the 36th, they're viable for delivery, okay? They're okay. So if it's after the 36th week, this is term, okay? Preterm is any pregnancy that's terminating from 20 to 36 weeks, okay? A is abortion, which is before 20th week, and then living is simple, is all living children. So to give you guys an example, is you have a patient currently pregnant, okay? She has currently 3 children, okay? And yeah, she has 3 children and she's currently pregnant. Give me the gravida and the para. Para is basically all of this combined. Excellent. Gravida 4, para 3. Excellent. Good. Very much that's it. Now, if you have another patient who is currently pregnant, has 6 kids, she says that in 2 of her previous pregnancies, she had 2 abortions before the 20th week. What's the GT-PAL? Good. So she had 6 before, current one. So it's gravida. I think it's gravida 7. Okay. Para 6, and then abortion 2. You don't count those. Okay. Because it's before 20th week. After that, yes, you count it. Okay. So it's gravida 7. So now you will get a question on this, by the way. But it will be more simpler than the one I just gave you. It will be like the first one. Someone who has 3 children and is currently pregnant. Okay, and what's the GT problem? Okay, so it's very simple, inshallah, in the exam. Now, important thing is how do you calculate the expected date of delivery? P is para. Basically, it's the total number of children, okay? And then you add 2, okay? Unless it's in GT PAL, but if it's just gravida para is a total number of children, okay? So basically, if I say gravida, it's number of pregnancy, P is the number of births, okay, including the abortions and everything, okay? Does that answer your question? But if it's in GT PAL, it's preterm. Okay. Now, something in obstetrics that's very important is calculating the expected date of delivery, okay? So you do it by using this rule. Firstly, you need to get the first day of the last menstrual period, okay? And it has to be that this patient has regular menstrual periods. This is the only important thing that's making you use this rule. If they have a regular menstrual period, you can't really use this rule. It's going to be inaccurate. Then what you do is either subtract 3 months or you add 9 months. Okay? Then you add 7 days to that. To give you guys an example, and we'll do this together. Someone had her last menstrual period and it was regular January 7th of 2023. What's their expected date? Excellent. October 14. You add 7 days. Okay, so October 14. Excellent, good. Okay, again, first day of the last menstrual period, then you add 9 months or subtract 3 months, whatever is easier for you, and then you add 7 days. Okay, this will be October 7th, 2020, sorry, October 14th, 2023. Okay. Now, you don't have to memorize all of this. I just brought this to pinpoint important things to memorize in antenatal care. Antenatal care is throughout pregnancy, okay? Even pre-pregnancy and post, okay? Now, let's talk about this. Firstly, let's talk about before the pregnancy. What do you advise a patient to take before the pregnancy? Folic acid. Excellent, good. And when should they stop taking folic acid? Or when should they continue taking it? Usually throughout the first trimester. Okay, they take it, they continue taking it. Okay. Now, if you are diagnosing, or sorry, not diagnosing, if you are, uh, let's just say, if you have a pregnant female in the first trimester and you're trying to indicate the expected date of delivery, what's the best way to do that in the first trimester? What's the most accurate way of knowing that? Crown rump length. Excellent. Okay, through ultrasound, yes. Okay, ultrasound crown lump length. Okay, perfect. Now, 11 to 14 weeks, very important, is you do something called nuchal translucency. What is that looking out for? Do you guys know? What are we checking in? Chromosomal abnormalities. Excellent, such as Down syndrome. Perfect, good. Obviously, in the first trimester, you do a lot of different screening tests, such as CBC, blood grouping, and antibody screening is very important in pregnancy because of something called RH immunization or alloimmunization. Fasting blood sugar, and we'll talk about this in a second, and some infections, okay? We'll talk about infections in a bit. Then 20 to 23, you do detailed anomaly scan, okay, later on. Then very important is this 24 to 28 weeks. What do you do at 24 weeks of pregnancy? What one lab test? I just want one lab test that you want to do. You're checking for diabetes. What lab test you want to do at 24 to 28 weeks? OGTT. Good. You do oral glucose tolerance testing to check for maternal diabetes, 24 to 28 weeks. This is so important, okay? Very important. The next important thing is when you do GBS screening. Thirty-six to 38 weeks, usually 37 weeks. Okay, yes, third trimester, but very late. Okay, you guys remember what GBS was? Group B strep, good. Causes meningitis, sepsis, pneumonia, neonatal. Okay, very important. Okay, GBS. So that's basically this. Now, important thing in pregnancy here, what type of vaccines can you not give in pregnancy? Live, just simply live attenuated vaccines, such as rubella, varicella, and some other ones. Okay, you cannot give it in pregnancy. Okay, now you have a group of infections that can happen in pregnancy that can lead to abnormalities in the fetus. What are these infections? Give me the term that I give to these infections. Torch infections. toxoplasmosis, others such as HIV and so on, rubella, cytomegalovirus, herpes, HIV, and so on. Okay, so these are the torch infections. Okay, these can cause severe malformations and infections in the fetus. Okay, now other than that, what other if you have a patient who has hypertension in pregnancies, what drugs can you give them? Hydralazine, good. Give me the other one. Nifedipine, give me a beta blocker that I can use. Methyldopa, one more. Labetalol, excellent. So you have nifedipine, hydralazine, methyldopa, labetalol. If you have a patient with hypertension in pregnancy. Now, for diabetic patients, someone has maternal diabetes, what drug can you give them? Simple. Insulin. Excellent. Good. Now, a patient with known epilepsy, can you give them anti-epileptics? Or is it teratogenic? So if someone was already controlled, they can continue or look for alternatives. If someone has epilepsy, you kind of need to help them. Now, very important. If someone has epilepsy in pregnancy, what drug do you give them? Or I'm going to give you another scenario. Someone has hypertension in pregnancy, and I'll talk about this disease. Later got seizures from this hypertensive disorder. What drug do you give them? Do you guys know? Magnesium sulfate. Good. Okay, this is very high yield. Eclampsia or seizures, magnesium sulfate in pregnancy. Okay, this is pretty much the entire antenatal care lecture and the entire pharma teratogenic lectures with some stuff that I missed. Okay, this is the high yield stuff. Okay, now in terms of the ultrasound findings, what do you see in this? And it says it here, but what is it showing? No, this is in the uterus. Gestational sac. Good. The double decidual sac sign is a sign of just, it shows you that there is a gestational sac, which happens at what week of gestation? When can you see this? Fifth week. Excellent. How about this? What's showing you? Yolk sac. Good. What week can you see this in? Sixth week. Excellent. Remember these, okay? This was read in your radiology lecture, okay? So remember gestational sac, fifth week, yolk sac, sixth week, okay? Now, what are they doing here? The first image, crown rump length, which is the most accurate way of dating pregnancy in the first trimester, okay? The second one is nuchal translucency, excellent. Now, this patient has thickened nuchal translucency, so what do you think they have? And we already mentioned Down syndrome or chromosomal anomalies. Good. Okay. Now, in terms of twins, something to remember is when do we have dichorionic, diamniotic? When do we have mono? When do we have conjoint? What does that even mean? Okay. Dichorion means basically the number of what's it called? Of the gestation of the sac, the amniotic sac. Amnion is the placenta and the umbilical cord. Okay, so now let's talk about when each of this happens. This relates to the division of the zygote. Okay, at what day it divides. The earlier the division, the more separated they are. The later the division, the more joined together they are. That's a way to remember it. So below 5 days, if they, for example, split around 3 days, they will have two different amniotic sacs and two different placentas. So this is dichorionic, diamniotic. Okay. If it divides around 5 to 7 days, it will form monochorionic, one amniotic sac, which is an amnion dividing them, and this, which is the diamnion and monochorionic. Okay, one chorion. Not gonna lie, I'm very confused with that, not gonna lie. But anyways, let me explain it in like my own terms to separate this. But basically, the chorion is this way. It's facing the mother. So you can say yes, one placenta. Excellent. Actually, yes, one placenta. And then if they have two different placenta, this is dichorionic. One placenta, this is monochorionic. And then the sac is amnion. Okay. So yes. So dichorion, two placentas, or a fused placenta with two umbilical cords like this. And you can see that they have two different sacs. Okay, hence it's called dichorionic, two different placentas, two different amnion. Here they have monochorionic, one placenta, okay, with two different amniotic sac. That's why you have this line that's dividing the two amnions, okay? Then we have mono, which usually when it divides from 8 to 12 days, and this is monochorionic, monoamniotic, hence it has one amnion and one chorion, one placenta, okay? Now, conjoined twins, if it divides past 15 days, okay? Does this make sense to you guys? Because I myself was confused for a bit. Yes or no? Or do you want me to repeat this? Tell. Dichorionic, diamniotic. Again, it divides when it's around day 3. Earlier division, it'll separate more. So day 3, okay, around day 3. Or below day 5, if you want to remember that. 5 to 7, 5 to 7 will be monochorionic, diamniotic. Okay, one placenta, two amniotic sacs. Okay, this is 5 to 7. 8 to 12 will be mono. One placenta, one amniotic sac. So they'll be together, swimming in the same sac. Conjoint, meaning that they're going to share the same body. Okay, this will be after 15 days. Is this clear? Okay, perfect. Now, very important thing to remember is miscarriages. Now, it's important to remember when miscarriages happen is the number 20. If it's below 20th week, this is what we call miscarriage or abortion. Now you need to know the types of miscarriages. This is very important. Now, the first patient over here has a closed cervix, closed cervix. Fetal cardiac activity is high, but they have a bit of bleeding. What type of abortion is this? Good. This is threatened abortion. Excellent. Okay. Threatened abortion when there's just bleeding. The fetus is fine and the cervix is not dilated. Okay. If the cervix is dilated, then this is something else. Okay. So this is threatened abortion. Okay. That's pretty much, remember this. Fetal heart rate is good. Cervix is closed. The fetus is fine, just blood. Okay. Then we have this next one. The fetal heart rate could be there, could be not there. Important is there's a dilated cervix and there's a lot of blood. Inevitable. It will happen eventually. Okay? This is an inevitable abortion or miscarriage. This one, completely absent cardiac sounds, fully dilated cervix, and you have some fetal parts still remaining in the uterus. What type of abortion? Incomplete. Excellent. Now, fetal heart rate is gone, cervix is closed, and lastly, you have no more fetal tissue inside the uterus. Complete. Excellent. Okay. Now, this last one, no fetal tissue. Sorry, Fetal tissue is still there. No bleeding, closed cervix, and no fetal heart rate. Blighted ovum, excellent, or missed miscarriage. Good. Remember these are this table, okay? Because you'll get it in this exact form, okay? Like the question will be someone, like I'll test you guys. Someone has a dilated cervix, no fetal heart rate or fetal heart activity with some fetal passage. What type? Incomplete. Someone has a closed cervix, no heart rate, and there's still an ovum. Miscarriage. You will get it just like that. Okay. So memorize how these 5 different miscarriages presented as. Now there are some images that you need to remember based on the radiology lecture, which is this. What type of miscarriage is seen here? I'll help you guys. You can see there is bleeding. Okay. Some fetal tissue remaining, and then absent fetal heart rate. Incomplete miscarriage. This is a bit confusing, but just remember in an incomplete, there's no fetal heart rate, okay? Or maybe very minimal because of the remaining fetal tissue, but usually no, okay? Fully dilated cervix, bleeding, hence all of this activity, and absent fetal heart rate, incomplete abortion. Now you take samples of this and you see this. What is this? You see chorionic villi with no fetal parts. This is just simply a miscarriage. Yes. Okay. Again, you'll see chorionic villi. Why? Because this is part of the placenta. Okay. That's pretty much that. Now we'll talk about placental diseases and gestational diseases, which is very simple, inshallah. This patient has inflammation of the placenta. What do we call this? Infection, ascending infection of the placenta. Chorioamnionitis. If they have inflammation of the umbilical cord associated with it, this is phoenicitis. Okay, so this is chorioamnionitis and phoenicitis. Okay, which is usually an ascending infection. Okay, of any of the organisms, such as even GBS, Staph aureus, something goes up and causes infection of the placenta, which is called chorioamnionitis. If it involves the umbilical cord, this is phoenicitis. Okay. Now, how about if it causes inflammation of the villi of the placenta? What do we call it? Which is what this is. Villitis, okay? Which is basically the same thing. Ascending infection affects the chorionic villi, okay? Hence, you can see a lot of neutrophils and so on because this is an inflammation of the villi, okay? These images are not too important, not gonna lie. Just remember the words. Any villitis, neutrophils, infection, ascending infection. Okay, that's pretty much that. Now, these are very important, and I will tell you the high yield parts of this. Patient came to you in the 3rd trimester with painless bleeding. What is your differential? Placenta previa. Excellent. Placenta previa is basically a low-lying placenta, where you have the placenta that's over the os of the cervix. Okay, hence it covers over it, so you easily have bleeding. Now, for this patient, how would you want to deliver the baby? C-section. Good. Okay, good. That's the basic thing that you need to remember in your block. C-section. Okay. Details of that, inshallah, will be guiding next year. Okay, so this is placenta previa. Painless 3rd trimester bleeding. Painless. Okay. This patient had painful 3rd trimester bleeding. Abruptio placenta or placental abruption. Good. Okay. Which is basically separation of the placenta from the myometrium. Okay. Accumulation of blood, and this causes the pain. Okay. That's pretty much all you need to know. Painful abruption. Painless previa, okay? And you can see this is the placenta, this is it, and then this is where you have the myometrium. This entire thing is blood, okay? Blood. You have separation of the placenta, okay? And this is very dangerous, and usually you also managed with C-section, okay? Because it compromises the fetal blood supply, all right? So that's placental abruption. Now you have a patient who had a sexually transmitted disease, had gonorrhea long before, presented to you with severe right lower quadrant pain, vomiting, and has this ectopic pregnancy. Excellent. Ectopic pregnancy, pretty much. Pregnancy or implantation somewhere that's not in the uterus. Okay. Most common location is where I said this before. What is the most common location for an ectopic pregnancy? Ampulla of the fallopian tubes. Excellent. Good. Okay. What you see in ultrasound is this is the fallopian tubes. This is where the ovary is. Is it supposed to be here? No. Okay. This is the uterus. This is the ectopic pregnancy. Is it supposed to be there? It's supposed to be in here. Why is it outside? Okay. Ectopic pregnancy. Here, same thing. Now, how do you diagnose it? Ultrasound. Okay. Plus beta HCG. Beta HCG will not be as high as a normal pregnancy, hence, because it's ectopic, it's not in the normal place. So it'll be less than normal. Okay. So that's ectopic pregnancy, and you treat it surgical mostly. You can give a certain drug. Do you know what drug you can give for ectopic pregnancy? Methotrexate. Excellent. Good. Perfect. You can give methotrexate, however, usually use surgical management if it's very complicated and stuff, and you don't need to worry about that. Okay. So this is ectopic pregnancy. Okay. Risk factor, tubal scarring, pelvic inflammatory disease, using an IUD, for example, any previous surgery, okay, of the pelvic area, gonorrhea, chlamydia, causing pelvic inflammatory disease, and so on. Okay. So this is ectopic pregnancy. Now, gestational trophoblastic disease is a very high yield topic, and you will get it in your exam multiple times. Now, just quizzing, because it's all just one simple big review and memorize this one table and a few images related to it. Now for the karyotype. Complete mole. What's the karyotype for the complete mole? Most common. 46XX. Okay. Partial mole. 69XXY. Okay. Now, components of it, don't worry about this actually, but basically, one sperm goes to an anucleated ovum, goes in, it's 23, duplicates to 46XX. That's what causes complete mole. Partial mole, two sperm with one egg. Okay, hence 69. Okay, 23, 23, 23. So that's pretty much what causes partial mole. So that's the components part. Histology. The most important way to differentiate complete to partial is what in histology? Or generally, what do you see in partial that you don't see in complete? You never see fetal parts, okay? You'll have hydropic villi mostly in complete. However, you will never see any fetal parts, okay? In partial, you'll see some hydropic villi, but you will see fetal parts, yes. Now, which one will have an increase, a higher uterine size, complete or partial mole? Complete, good. HCG will be higher in which one? Complete, good. What is the associated image that you see with complete mole? Snowstorm appearance, good. Now, someone mentioned grape-like features, and this is basically how they will present, okay? They will say, oh, it's very early in the pregnancy, very early, but their size, like the abdominal or uterine size is very, very big, and they pass grape-like structures, okay, from the vagina, okay? That's typically how they present with. Imaging we mentioned. Which one will have a higher risk of invasive mole, complete or partial? Complete. And which one have a high risk of carcinoma? Complete. Good. So that's pretty much stuff. What is the diagnosis, and what do you see? Complete mole, snowstorm appearance. You will 100% get this in your exam. Okay, I almost can guarantee it. Okay, you'll get this. Complete mole. What type of mole is seen here? Complete, excellent. No fetal part, hydropic villi, as you can see clearly. Okay, very, very edematous and big. Grape-like structures. And here you will see no fetal parts and very big uterus size. Okay, complete mole. What complication occurred here? Choriocarcinoma. Excellent. And we already talked about this in the ovarian. Okay. Now, very important is the hypertensive disorders in pregnancies. Gestational diabetes, gestational hypertension is basically hypertension more than or blood pressure more than 140 over 90 after the 20th week. If this is before the 20th week, this is called pre-existing hypertension. They already had hypertension, okay? So then it basically it's just continuation of that hypertension. If they had no pre-existing hypertension and it was diagnosed after 20th week, then we can say this is gestational hypertension. Now, this is gestational hypertension with no proteinuria or and organ damage. If you have someone who has a blood pressure over 140 over 90 with proteinuria and organ damage, what do I call this disease? Preeclampsia. Excellent. Now, the important thing about preeclampsia is it's caused by abnormal placental spiral arteries. That's all you need to know about this, okay? Risk factors is obviously it's just a bunch of stuff. Anyways, complications is everything, okay? Placental abruption, renal failure, pulmonary edema because it causes end organ damage, and it can cause abortion, okay? And miscarriage. Now, it can lead to two important diseases, eclampsia and HELLP syndrome. Eclampsia is preeclampsia with what? What symptoms? Seizures. Okay, good. HELLP syndrome is preeclampsia with hemolysis, elevated liver enzymes, and low platelets. Tamam. Important thing is how do you manage it? Gestational hypertension and preeclampsia, typically, you manage it with these four antihypertensives. Hydralazine, methyldopa, labetalol, nifedipine. We already mentioned this. If they have eclampsia, you give them magnesium. Okay? Even with patients with preeclampsia, you give them magnesium to prevent seizures. Okay? That's pretty much that. Okay? HELLP syndrome, immediate delivery, it's very dangerous. Okay? They'll have hemolysis, so they'll have drop in hemoglobin, high LDH is a sign of hemolysis, jaundice maybe, elevated liver enzymes, ALT, AST will be high, low platelets, low platelets. Okay? Very simple. And you'll get these lab values clearly thrown to you. Okay? So it's not really that difficult. Now, for the drugs in pregnancy, you need to just understand labor very quickly. Labor has 3 stages. I'll describe the stage and you tell me which stage. Fully dilation of the cervix. What stage is that? Do you know? Fully dilation of the cervix. Okay. So you have in labor 3 stages. Stage 1 is dilation of the cervix. It's divided into two, below 6 centimeters and above 6 centimeters. Okay. Above 6 centimeters is called stage 1A or 1B, below is 1A. Okay. Something like that. Stage 2 is delivery of the fetus. Stage 3 is delivery of the placenta. Okay. These are the stages of labor. Now, important thing is if you want to induce labor, okay, you need to look at one thing, which is the Bishop score, which is basically going to tell you how dilated the cervix is, how effaced the cervix is, how ready the cervix is to basically deliver the baby, okay, and how ready it is, okay. The key number is 6, and also for the size of the cervix, the dilation, 6. If it's below 6, what drug do you want to give to induce labor? Prostaglandin. Excellent. Why prostaglandin? It will ripen the cervix. It will dilate the cervix. Excellent. Okay, it will continue that dilation till 10 centimeters, which is the maximum. If it's already above 6, the Bishop score, what drug can you give to induce labor? Oxytocin. That's pretty much it. Okay, this is the drug. And these are the two drugs that you need to remember. Prostaglandin, you give it if it's a Bishop score below 6. There's multiple forms, misoprostol, and then you have Prepidil and Cervidil. And they're used for cervical ripening. Okay. Now, important thing I think is this. For Prepidil, the dose can be repeated in 6 to 12 hours. If the cervical change is not adequate. Cervidil is up to 12 hours. Okay. That's the important numbers you need to memorize for your exam. Dr. Dana emphasized on that, I think. Okay, anyways. In terms of the side effects, tachycystole, which is basically the fetal heart rate will be very high. Okay. That's pretty much it. And hyperstimulation and the uterine contractions will be very, very high. Okay. Which will lead to high heart rate of the fetus. Tamam. Oxytocin, it basically will cause uterine contractions. Okay, so it induces it. You need to be sure that the cervix size is fully dilated. It's above 6. Okay, the Bishop score is above 6. Again, what's the risk factor or what's the side effect? Hyperstimulation, tachycystole, and then uterine rupture because you're contracting the uterus and so on. Okay, and these are other side effects of oxytocin. Now, the opposite of induction of labor is tocolytics or tocolysis. It's to stop, okay, abortion. Stop labor, sorry. Now, in terms of the different tocolytics, some of the ones you need to remember is COX inhibitors, okay? Very important COX inhibitors is a side effects. Now, in terms of the number of weeks, if it's given after 32 weeks, what side effects does endomethacin cause? Or NSAIDs, COX inhibitors. Narrowing of the ductus arteriosus, which will cause cyanosis and a lot of pulmonary hypertension and so on. Okay, so you don't. If it's below 32 weeks, yes, you give it. Okay, another one is nifedipine. Okay, and it's the first line in patients below 32 weeks who have contraindications to endomethacin, and first line in above 32 weeks. So before 32 weeks, if they don't have no contraindication to NSAIDs, you give endomethacin to stop labor. If it's above 32 weeks, then you can give nifedipine. Okay, the rest aren't too important. You just need to remember these two. Okay, indomethacin, after 32 weeks, you can't give it. Below 32 weeks, it's first line. After 32 weeks, you can give nifedipine. If they have contraindication to endomethacin, such as, for example, GI bleeds, renal insufficiency, and so on, you can give nifedipine. Tamam, that's pretty much that. And then we said already, magnesium is an anti-epileptic. You give it in preeclampsia, eclampsia, because it has protective effect of the fetus and it's to stop the eclampsia. Okay. That's pretty much it for pregnancy and obstetrics. We have time, inshallah, so we'll go over the breast, all of it now. You guys have any question for obstetrics? Good? Okay. Now, the last part of this whole crash course is the breast. Simple, benign, and malignant changes. That's pretty much all you need to know about the breast. Okay. The benign and malignant features and the different genes that's associated with it and how it looks like. Okay, and how it presents with. That's pretty much all of the breast. So let's talk about simple anatomy first. Is the breast is divided into multiple quadrants, and we already know this very well. Okay, so you have the upper outer, upper inner, lower inner, which is this one, and then lower outer. Okay. From these 4 quadrants, what is the most common location for cancer? Which quadrant? You guys know. Okay. Yes, the most common location is the upper outer, which is this. Okay, which is closer to the axillary tail. Okay, all of this. This is the most common location. Tamam? That's pretty much the only important thing about the anatomy. It's under the breast tissue. You have the pectoralis major, pectoralis minor, Important thing about this is sometimes in a surgery called complete mastectomy or a radical mastectomy, you remove everything. Okay, so you remove these muscles with it. I don't think you need to know that. Okay. And then here's axillary lymph nodes, which is very important and high yield in breast cancer. Okay, because usually you biopsy these, which is called sentinel lymph node biopsy, which is in the axilla. And it's basically helps you with the staging and treatment of breast cancer. Okay. Now, mammography. Now, mammography is one of the important images. There's two imaging modalities you do for the breast, mammography and ultrasound. Okay. This is mammography. Important thing is you need to know the basically the field of view that you look at in a mammography. What is the field of view of this one? Medial, lateral, oblique. Excellent. How about this one? Craniocaudal. Excellent. Good. Basically, medial, lateral, oblique is if you're, it's basically a machine that will press on the breast laterally. Okay, so it'll give you medial lateral view. And the way that you remember that this is MLO is this, which is the axillary tail. Okay, if you see this, خلاص, you know. Craniocaudal is different. It looks at it from top to bottom. So the machine presses from top to bottom like this. Okay, so this is craniocaudal. Now, important thing to remember about mammography is its effectiveness at detecting pathologies is limited depending on how dense the breast is. It's effective by breast density. Okay. Now you have a score, a grade, depending on how dense the breast is. If it's below 25, it's 25 to 50, 50 to 75, and greater than 75% density. This breast over here, what do you think the density is? Below 25, 25 to 50, 50 to 75, or more than 75? Below 25. So what do you think the age of this patient is? Postmenopausal. Okay, over 40. Okay, so this is that. This is very important to remember the number 40, and I'll explain in a bit. This patient, below 25, 25 to 50, 50 to 75, or 25 to 50. Good. This patient, 50 to 75, and this patient, over 75. What do you think the age of this patient is? Give me a range. I don't care. Young. Good. Young patient. Very important thing is if you have a patient who is below the age of 40, the key number, what imaging modality do you prefer to use? Ultrasound. Excellent. Good. If they are above 40, mammography. Excellent. Good. Now, if you want to, if you see, for example, this pathology, I won't, like, if they have a pathology over here, let's just say, and you want to take a biopsy, what is the biopsy method that you do? Core needle biopsy. If you see a cyst, what would you do? FNA. Excellent. Good. Perfect. Okay. Pathologies of the breast, the way you do biopsy, core needle biopsy. In the thyroid, it was fine needle biopsy. If they have a breast cyst, you do FNA to drain that cyst. Okay. And then you send it to cytology and you do stuff to that. Okay. So that's basically the breast images and the diagnostic methods. Okay. Now, in terms of histology, the breast is divided to lobes, around 10 to 15 lobes. The lobes are divided, this is one big lobe. Then it's divided to lobules, and in the lobules you have acini and ducts. Okay. So this is an acini. Important thing to remember is the layers. How many layers does it normally have? 2 layers. Excellent. The first layer is epithelial. The second layer is what? Myoepithelial cells. Good. Okay. Increase the number of the pathologies. Okay. That's pretty much that. And this is basically the ducts of the, I don't even know why I put the slide on the line, but this is the ducts. Okay. Now, the breast pathologies, very important to know where it comes from. Okay. Now, the most important is the lobules and the ducts. Okay. In the lobules, you have ductal hyperplasia, cystic changes, all these different changes that happens. Also in these ducts as well, Paget's disease in the major ducts, especially around the right under the areola and the nipple. And you have intraductal papilloma, and I'll explain clinical features of that. If it comes from the stroma, it has two pathologies, fibroadenoma and phylloides. Okay, we'll talk about them later. From the stroma, the interlobular, not interlobular, not intralobular, interlobular between the lobes, you have the stroma and fat, you have fat necrosis, which is very important, fibrous tumor, lipoma, and so on. Okay, these are all the pathologies, and we'll talk about them one by one, all of these mainly. Okay, this patient, this is a large duct, and it's blocked by something. Okay, good. Duct ectasia. Does it have a discharge? Yes or no? Yes. What? Yes. What is a discharge if you know the description of it? Not bloody. Does it have a specific color? Green. Okay. Green discharge. That's mammary duct ectasia. Okay. I'm not sure why, but usually it's how it's described. You know, a green discharge, duct ectasia usually is the cause of it. Okay. Just something to memorize, yeah. And if you see it in the question stem, green discharge, you think of duct ectasia. Okay. Bloody discharge, we'll talk about. There's an important cause of bloody discharge. Okay. Now, a patient, let's just say female, is a football player and they were hit while playing. Later on, presents with a mass, okay, in the breast. What is it? Fat necrosis. Good. Simple. Following trauma, okay? Following any trauma to the chest, okay? That is typically how it will present with, okay? And that's typically why it happens. It's necrosis of the fat because of the trauma that causes inflammation of the adipose adipocytes, as you can see here, okay? Fat necrosis. Now we look into this patient who has cyclical breast pain, mastalgia. Good. Fibrocystic change, okay? Or fibrocystic disease. Keyword is cyclical breast pain, okay? With the menstrual cycles, typically how it presents with, and it's very, very common, okay? One of the most common breast pathologies. Cyclical breast pain, remember those words, okay? Fibrocystic disease. Now, what happened to this patient? Good, hyperplasia. What is the risk of cancer or malignancy that they have? Number. I want the number. 1.5 to 2 folds. Good. Okay. This is epithelial hyperplasia. How do I know this is epithelial hyperplasia? Normally you have two layers. Here you have many. Okay. So this is epithelial hyperplasia. Has a risk of cancer 1 to 2 folds, or 1.5 to 2 folds. How about this one? They have one of the causes of hyperplasia, but what type of it? Or one of the causes of uh can cause malignancy later. Sclerosing adenosis, good. Sclerosing adenosis, you have fibrosis that's occurring in the lobule itself, okay? And this fibrosis and this whole disease, sclerosing adenosis, also has a risk of malignancy of 1.5 to 2-fold, okay? That's it to remember about this. More importantly is this image. This is a high-yield image. Radial scar, good. Again, it's basically sclerosing adenosis that became much worse, and you have a lot of extensive fibrosis occurring. So this is complex sclerosing adenosis with a radial scar. Memorize this image, very important. Again, the risk of malignancy is 1.5 to 2-fold. Okay. Now, you have this patient, let's just say, premenopausal woman with a bloody nipple discharge. Intraductal papilloma. Excellent. Good. Bloody discharge. Remember, Premenopausal, introductive papilloma. Postmenopausal, usually papillocarcinoma or just adenocarcinoma. Okay. But it has to be papillary. Okay. Remember, introductive papilloma, bloody discharge. If you get that, most likely it will be papilloma. Okay. This is the most common presentation of introductive papilloma, bloody discharge. Why? It's usually right under the nipple. Okay, right under. So it's in a major duct, very large duct. So hence it causes bloody discharge. Okay, that is introductive papilloma. Now, how about this patient? What do they have? Let's just say a male patient who has breast tissue, gynecomastia. Another case that you see gynecomastia, liver diseases, if you remember from GIT. You also have, for example, a patient who is taking specific diuretic like spironolactone. You also have it, it's normal in puberty. They can have it in elderly, they can have gynecomastia. And then this is basically breast tissue, okay? Develops in males, okay? Gynecomastia. So that's basically that. Now, this patient, very important, has a mass, painless mass that's mobile and can move. Fibroadenoma. What do I call this in imaging? Do you guys know? Popcorn calcification. Good. Popcorn calcification. Okay. If it's microcalcification, micro, very small and spread out, this is more malignant feature. However, this one, the calcification is very near, big, and it has a description, which is popcorn calcification, fibroadenoma, okay, which is a benign mass, okay? So that is fibroadenoma. Now, a counterpart to fibroadenoma is something that's a bit more malignant, has more malignant features, and has this feature, phylloids tumor. It has more malignant risk, so hence, in breast surgery, we look at it as as an indication to remove the breast, okay? Because it has a very high risk of malignancy, and it has this leaf-like pattern, okay? Or leaf-like finger projection, okay? Which is very important and high yield picture for your exam. Phylloids tumor. You will get this in the exam. So it's like fibroadenoma in terms of where it comes from, which is a stroma, and it has a higher risk of malignancy and has this finger-like projection or the leaf-like projection. Okay, phylloids. Now, for breast cancer, very important to remember two genes, BRCA1, BRCA2. And lastly, you need to remember the estrogen and HER2 positivity. Okay. Why is estrogen and HER2 very important? Is because of treatment. Okay. And how severe the disease is. Let's talk about this. If someone has a BRCA2 mutation, will they have estrogen receptor positive or negative? Usually. Positive. How about HER2? Negative. Good. If they have P53 mutation, what type of let's just say marker will be positive or receptor? HER2 positive. Good. If they have BRCA1 mutation, both negative or triple negative. The other receptor is progesterone receptor. Okay. So these are that's basically it. Okay. If they have BRCA2 mutation, estrogen receptor positive. Okay. HER2 negative. If they have TP53 mutation, HER2 positive, ER negative. Okay. If they have BRCA1 mutation, they'll have double negative or triple negative. Okay, typically triple negative. Why is this important for us? Treatment. If someone has BRCA2 mutation, has ER positive, how can you treat it? And if they have ER positivity, what can I give to these patients? Tamoxifen, excellent, or raloxifene, selective estrogen receptor modulator. Okay, SERMs. Good. If someone has HER2 positivity. What drug can I give? Do you guys know the drug? It's very important. Trastuzumab, excellent. Or has Herceptin, which is trastuzumab. Okay, very important. Triple negative is a bit different and it's harder to treat. Okay, way harder to treat and it's a whole hassle on its own. Okay, that's it to remember about the genetics. BRCA2, ER positive, treated with SERMs. TP53, HER2 positive, trastuzumab. BRCA1, all negative, complicated management. Okay. Now, very important is something called BI-RADS classification. Okay. Basically, it's it tells you if something is suspicious, something is benign, something is normal, and it basically dictates your management and what you do next. Okay. It's basically a classification of six. Okay, there are six scores. Starting with zero, so technically you can say seven. Okay, but zero basically is that they need additional evaluation. We don't know what they have yet. So what we do for them is a mammogram or ultrasound. If they are above 40, which one do we go for? Mammogram. If they are below 40, ultrasound. Good. If we do a screening mammogram, which is usually above the age of 30, and they have nothing on mammogram, what do? You just screen them. Okay, regular. Okay, they are normal. If they probably have a benign lesion or they have a benign lesion such as a fibroadenoma, fat necrosis or something, they're normal. Okay, this is BI-RAD 2, benign lesion. If it's probably benign and you don't really know, it might have some features that's kind of bad, then you want to see them a bit earlier. Okay, such as if they have calcifications, but it's not really microcalcification, it's an oval mass, then you want to do screening a bit more frequently. Okay, so this is BI-RAD 3. The important ones are all of these. Okay, BI-RAD 4, if they have suspicious lesion, that's suspicious for malignancy. In this case, you want to do a biopsy. If it's highly suspicious, this is BI-RAD 5. And if it's proven by biopsy that it's malignant, then it's 6. The important is these two. BI-RAD 4 is suspicious. BI-RAD 5 is highly suspicious. Okay. Now, for BI-RAD 4 and 5, you need to do biopsy. How do you do biopsy again? What method? Core needle biopsy. Good. That's it. Okay. BI-RAD 6 is you proven that this is, for example, invasive ductal carcinoma through biopsy. You manage it. Do a mastectomy. Give them drugs. Okay, whatever. This is BI-RAD 6. The confusion is between these two. Okay. Now, what do you see on this image? Just tell me what you see. Don't tell me the BI-RADs. Don't tell me anything. Microcalcifications. Is this a sign of malignancy? Yes or no? Excellent. Yes. Okay. Microcalcifications. Now, this patient has an oval mass that has a solid component. It doesn't look that neat. The borders are a bit, it's not really regular, and has multiple septations here, and it's a microcyst. Does this show you malignant features? Yes or no? I just want this for now. Yes. Is it suspicious or highly suspicious? What do you think? I would say this is just suspicious. Reason why is look at the borders. It looks like it's still an oval. There's some irregularity here. However, it's not fully irregular. Okay, it's not distorted. So I would say this is suspicious. So what BI-RAD score is for suspicious? BI-RAD 4. This is 3 apparently. Probably benign. So anyways, go for BI-RAD 3 for this one. I would go for 4, not gonna lie with you. It's BI-RAD 3. Okay. It's probably benign, but you need to do short intervals, okay? How about this patient? Microcalcification, irregular border. And you can see this mass that's not regular. What birad is this? 5. Okay. Just memorize these two images. It was read in radiology. That's why I put them. I myself, I would not get these right, not gonna lie. But just memorize these three images for BIRADS 3, these three for BIRADS 5. Okay? Just memorize them, please. Okay? Very low yield stuff, not gonna lie for you guys. It's involved. Now, high yield is this. This patient, let's start from here. This is the mass. Okay? What do you think this mass is? Let me give you a description. Mobile mass. Fibroadenoma. Good. How about this mass? Lipoma. Why do you say it's lipoma? Give me one reason. Isodense. Excellent. Good. It's fat. Okay. Perfect. How about this one? Tell me, is it benign or malignant? Malignant. Good. Give me two reasons why you think this is malignant. Nipple inversion. Excellent. Perfect. Uh, thick skin. Sure. Give me another reason. More important. Stellate. Excellent. Excellent. Good. The borders. It's irregular, very irregular, and it's basically diffusing into the breast tissue. Okay, this is a malignant feature. So fibroadenoma is the first one. This one is lipoma, and this one is malignancy. Good. Here again, what is this one? Malignant, same reasons. Okay. The second one, what do you think it is? Multiple densities, very different densities. With it's glandular tissue with stroma with everything, but it's in its wrong location. So what do I call this? Hamartoma. Excellent. Good. This is a hamartoma. Normal tissue, just wrong place for it. Okay. Glands, stroma, everything just irregular. Okay. This third patient, what do they have in this one? What is this lesion? Lipoma. Again, isodense. Okay, good. Now, this patient, what do they have? It's anechoic, okay, with posterior enhancement. Cyst. Sorry, no, it's not a cyst. This is a fibroadenoma. It's not really anechoic. The next pictures I'll show you anechoic. But this one is hypoechoic, and it has no posterior. I'm really tired. Posterior enhancement. So this is a fibroadenoma, okay, with the oval shape. This is a fibroadenoma. How about this patient? Benign or malignant? Malignant, good. And I have a final this Thursday colonoscopy, but everything's a bit messy. Okay. Now this. Okay. Um, what do they have? Microcalcification. It's in the duct. However, it's not invading the basement membrane. What do they have? Ductal carcinoma in situ. Now, DCIS has many different subclasses and divisions in terms of the feature. You guys need to identify these. Okay? This first one. What is this type? Comedo. Good. Which is basically it's closing on the duct. It's hemorrhagic fluid or just basically cells that's closing the duct. This is comedo. Okay? DCIS. How about this one? Papillary projections. Micropapillary. Good. How about this one? Cribriform. Good. Okay. Memorize these images, especially this one and this one. Okay. These will come. They'd love to ask Comedo and this one as well. They're both the same. Comedo and micropapillary usually. Okay. Now, this patient has a like a lesion over here that's a bit bloody. What is it? Paget's disease. Good, excellent. Which is basically you have intraepithelial neoplastic cells. Okay, that's pretty much Paget's disease, similar to extramemory Paget's disease that we talked in the vulva. Okay, now how about this patient? Good. This is lobular carcinoma in situ. Now there is a specific uh no, okay. Is it ECAD here in positive or negative? Negative. Good. The thing about ecadherin is you guys know the normal function of ecadherin? Six cells together. Excellent. Good. So if it's adhesion, excellent. Good. So if ecadherin is not there, it won't stick cells together. So when you have carcinoma, lobular carcinoma, it has a specific feature. Again, we'll talk about this in a bit. Now, what happened to this patient? Ducts, but it's no longer in the basement membrane and it's spreading everywhere. Ductal carcinoma. Good. Okay, invasive ductal carcinoma. This one, Indian file, good. Which is what type of tumor? Cancer? Lobular carcinoma. Excellent. Good. Lobular carcinoma, the Indian file line. Okay. Because of what? What's negative? Ecadherin. Good. Okay. Remember ecadherin. Now, how about this patient? Medullary. Good. Okay. Now, there is one subtype of carcinoma that they didn't talk about. I don't know why in this block, but it's very important. Uh, Peau d'orange. What type of carcinoma is this associated with? Orange peel appearance. Inflammatory breast cancer. Good. Okay. Perfect. This patient, what do they have? A lot of secretions, which is mucinous. Exactly. Mucinous. Good. Mucinous or colloid carcinoma. Okay, which is all of this. You see all of this mucin. Okay. This is mucinous or colloid carcinoma. There's one. Good. Tubular carcinoma, tubules everywhere. Okay. This is not too high yield, not gonna lie to remember the image. I don't think a lot of these are. It's just mostly the lobular is the most high yield image from the cancers itself. Okay, that you need to know. Now, the last few slides of this entire crash course, and we are done. Okay. Now, I already mentioned this, is if you have a patient with P53 mutation, what will their basically their will it be ER positive? Yes or no? No. Will it be HER2 positive? HER2 positive. Excellent. Good. So what drug can you give? Trastuzumab. Perfect. Trastuzumab binds to HER2, which is a tyrosine kinase receptor, and it basically does its action. Very important is its side effect, which is cardiomyopathy. Now, what drug can you never give with trastuzumab because of the side effect? Doxorubicin. Excellent. Okay, or anthracyclines. Perfect. Then you have a patient with BRCA2 mutation. Will they be estrogen receptor positive? Yes or no? Yes. HER2, will it be positive or negative? Negative. Good. So what drug will you give to this patient who has ER positive? Tamoxifen. Good. Tamoxifen is an estrogen agonist at what site? Agonist. Endometrium and one other organ. Bone. Excellent. So will this benefit patients with osteoporosis? Yes or no? Yes. Will this cause endometrial hyperplasia? Yes or no? Yes. Good. And it's an antagonist at what tissue? Which is the whole point of this. Breast. That's it. Okay. Side effects, it increases risk of venous trauma. Basically, think of estrogen. Okay, that's pretty much all you need to know. Then you have aromatase inhibitors, which we talked about earlier. Basically, same thing. It reduces estrogen production, and this will help any estrogen positive tumors. Okay. Now you have adjuvant chemotherapy that you use also. So yeah, for example, anthracyclines such as doxorubicin. Most important thing to remember is cardiomyopathy. Cyclophosphamide causes what as a side effect? Hemorrhagic cystitis. What do you give to these patients? Mesna, excellent, good. Okay, perfect. Methotrexate, you already know it inhibits dihydrofolate reductase. It causes myelosuppression. So what do you give to these patients who are taking methotrexate? Leucovorin, which is it folic acid or folinic acid? Folinic, good. Okay, not folic. Then you have 5-fluorouracil, which causes mucositis, myelosuppression, hand-foot syndrome. There's a picture of it in your slides. Then you have taxanes such as paclitaxel and taxels. You have neuropathy as its main side effect. Then bisphosphonates for patients who have a bone, it involves their bone density for osteoporosis, and you already know. Now you have neoadjuvant therapy. The ones you need to remember is mainly this and its indication, which is for CDK4/6 positivity, and atezolizumab, okay, for PDL1. Okay, that's pretty much this lecture. The most important concept is these two drugs. Okay, trastuzumab for HER2 and cardiomyopathy, tamoxifen, and where it acts on, which is this. Okay. And we are done with this crash course and endo repro everything. This is my last session and we're done. You guys have any questions? I kind of made a few mistakes at the very end. Forgive me for that. I got really tired. So yeah, anytime. If you guys need anything, you have my number and contact me if you guys need anything. Alhamdulillah. That was fun. No problem. Thank you very much. All right. Thank you guys.